Hello, my dear White Army members. Welcome to this Epignosis medical case presentation. I don't say competition, but maybe a mock examination kind of session. In the preliminary round, we had 150 plus registrations from all over the country as well as abroad. So many participants sending their abstracts, among which best 8 were selected for the final round, and which was a very, very difficult task, I should agree. And these 8 different variety of cases we have selected, and encompassing students from all across the country, so that we'll come to know like how to present a case, and also the perspective of students from different places, like what is their presentation styles. So this is going to be a self-assessment session rather than a competition, where we stand at this juncture before the exam. So judges will give you both the feedbacks, positive as well as the negative feedbacks, what you have to improve on, what are the good aspects. So accordingly, we can improve and do our best in the upcoming exams. So without any further ado, I would like to take this opportunity to introduce our esteemed judges, our own mentors of White Army, Dr. Akshay Rao sir, who is a consultant physician at in Bangalore, and also a mentor of Triple M course in our White Army, Medicine Made Memorable. Welcome to you, Akshay sir.
Hi everybody, thanks Kishan. All the best to all the participants. I hope it will be like Kishan said, an educative session for everybody. Thank you for having me.
And very good friend of mine, and very good teacher, very passionate teacher, and a good clinician, Dr. Rajashekhar Mulimani. He's also a mentor of White Army. You can see many wonderful classes by him in our channel. Welcome to you, Dr. Rajashekhar. It's really a great privilege to have you with us today.
Thank you, Kishan, and I'm very happy to be part of White Army. I'm happy to judge all the enthusiastic students presenting the cases here, so that it will be helpful for the main exam. Thank you.
And I always say, golden girl. She's the real golden girl, Dr. Deepti. Okay. She's academically, clinically, everywhere she has excelled. Okay. I think you are you are really lucky to learn from her or have you here with us. Okay. As a mentor. Dr. Deepti Agarwal, who has also done her DM in immunology. Immunology or rheumatology, Deepti?
It's clinical immunology and rheumatology.
Okay, both. Okay.
Exactly.
So there are some cases also related to that. So we can learn better from you today. So thank you for joining us. You have given us so many wonderful classes in White Army, many theory classes as well as motivational classes, how to excel in exams. Thank you so much. We are really grateful to you for all your contributions. Looking forward to learn much more from you. And I also welcome all our finalists today. And also host Mr. Aditya is with us today. So welcome you all for this session. And with the mentor's permission, we can start this presentations.
Yes. Let's go ahead.
Yeah.
First, we have Miss Samridhi Arora from who is a 4th year MBBS student at prestigious Lady Hardingham Medical College, New Delhi. Samridhi, are you ready?
Yes.
Yes. All the best.
Thank you. So I am presenting a case of Mrs. X.
Samridhi, 1 second. Can you please just move away the video on your screen, please?
Okay.
Yes. All. I think then your video is not visible. You are using only one device.
Yeah.
I think your video is not visible now. Put it back. Okay.
Is it visible now?
Is her video visible, Aditya?
Hello. Hello.
Yeah.
Okay.
No. You have to keep it. You have to keep the screen. Samridhi.
The screen is not visible.
No, not that screen. Your video screen. Yeah. Video screen. What you have put aside, no? Keep it. Or else it's not going to show your video. Yeah, this is fine. This is fine.
Okay.
Talk something. Yeah. You can
Hello.
start.
Okay. So I am presenting a case of Mrs. XYZ, whose age is 55 years, and she's a resident of Daryaganj. She is homemaker and she is educated till 10th standard. Her socioeconomic status is upper lower according to the modified Kuppuswamy scale 2024. The informant was a patient and her husband. The patient is right-handed and she speaks and understands Hindi. The date of admission was 1st May 2025 and the date of examination was 3rd May 2025. She came with the chief complaints of difficulty in walking and imbalance for 4 years, weakness in the lower limbs for 2 years, loss of touch sensation in the feet for 1 year, and slurring of speech for 6 months. History of presenting illness. The patient was apparently well 4 years ago when the patient complained of imbalance or unsteadiness while walking, which was leading to multiple fallings. She started having a slow, wide-based gait with swaying on either side as well as to the back. There was no history of tremors when she was reaching for objects, no history of overshooting acts, or any history suggestive of any abnormal eye movements. 2 years ago, she found difficulty in gripping her chappals. 1 year ago, she was finding difficulty in rising from the squatting position. To get up from the squatting position, she first used her upper limbs and trunk muscles for support and then got up. She is currently unable to walk for the past 6 months. She is able to roll over in bed. She is able to raise her head from the pillow without support. There is no difficulty in buttoning and unbuttoning the shirt, eating food, or combing hair. 1 year ago, she also complained of her being unable to differentiate whether she is having chappal on her feet or walking barefoot on floor. That is loss of sensation. She told that she could appreciate hot water from cold water while taking bath. She did not notice if she feels pain from any insect bites. There are no history of tingling sensation or burning pain in the limbs. The patient complained of slow, slurred speech for the past 6 months. The flow of words was affected and multiple pauses in between were present. No history of facial deviation or inability to close eyelids or drooling of saliva from mouth or loss of taste sensation. No history of dysphagia, nasal regurgitation, hoarseness of voice, or nasal intonation of speech was present. No history of dizziness or lightheadedness or vertigo or nausea or vomiting or decreased perception of movement or worsening of ataxia on closure of eyes was present. No history of headache or loss of consciousness before the onset of disease. No history of fever or rash or neck stiffness before the onset of disease. No history of cold intolerance, fatigue, weight gain, constipation, or menstrual changes before the onset of disease. No history suggestive of dementia. No history of resting tremors or mask-like face or stiffness of the limbs. There was no history of any lump anywhere in the body, no history of altered state of consciousness or difficulty to recognize people or objects or inappropriate crying or laughing or lack of interest or social disinhibition or history suggestive of delusions or hallucinations. No history of loss of color vision, smell, double vision, no history of alteration in facial feeling or problem in chewing, no history of vertigo, tinnitus or hearing abnormality, no history of involuntary movements, no history of abnormal sweating, urinary retention, or incontinence. Past history, no similar complaints in the past, no history suggestive of seizures, heart disease, asthma, COPD, diabetes, hypertension, TB or TB contacts, hypo or hyperthyroidism, STI or chronic drug use, no history of previous hospitalization, no history of any trauma or surgery. Personal history was not significant. Family history was significant. One brother had a drunken gait beginning at 48 years of age and he is unable to walk since 2 years. 2 sisters developed similar complaints of imbalance and multiple fallings and weakness in the lower limbs at around the same age, that is 50. There's no other significant history. Her father died around the age of 50 due to the alcoholic liver disease, and this is the pedigree that I have made for 3 generations. The dietary history was that the diet was deficient in fruits, nuts, and seeds. Otherwise, nothing abnormal. Summary: Mrs. XYZ, 55-year-old lady, resident of Daryaganj, homemaker, educated till 10th class with no known comorbidities, presented with complaint of difficulty in walking and imbalance for the past 2 years, with swaying to either side under the back. She also presented with lower limb weakness for 2 years, which was insidious in onset, gradually progressive in nature, which started from bilateral distal lower limb to bilateral proximal lower limb. For 1 year, she is having numbness in bilateral feet. There is also complaint of slurring of speech, with no history of any cranial nerve involvement. Similar complaints are present in siblings of the same age. There are no signs of autonomic dysfunction or meningeal irritation. Examination, the vitals were normal. The general physical examination was normal. nervous system. She was right-handed, educated till 10th standard. She understands, speaks and reads and writes in Hindi. Higher mental function was normal, except for the speech was slow and it was having multiple pauses in between, which is the scanning type of speech. In the cranial nerve examination, the cranial nerves were intact, except for in the third, fourth, and the sixth nerves, there was loss of fast saccadic eye movement with hypometric saccadus present. The other nerves were intact. Motor function, the attitude of the lower limbs, the bilateral lower limbs were extended at the hip and the knee, externally rotated at the hip, and foot was inverted. The muscle bulk was less in the at the calf muscles, in the tibial 10 centimeters below the tibial tuberosity, that is a mid leg circumference. Then the muscle tone was normal. The muscle power was in the hip, knee, and ankle on the right side, it was grade 3 on 5. On the left side, it was grade 4 minus on 5 for the hip, knee, and the ankle. The superficial reflexes, the plantar reflex was having dorsiflexion. The deep tendon reflexes were low in the patellar and the ankle region. Sensory examination was reduced in bilateral lower limbs for all fine touch, crude touch, vibration, pain, temperature, tactile localization, and 2-point discrimination. For coordination and cerebellar function, finger nose test was normal. Desired leukokinesia was absent. Heel to shin test was positive. Gait could not be assessed since the power of the muscles was 3 on 1 of the limbs. Nystagmus was absent. Romberg's test again could not be assessed as she could not stand. Rebound phenomenon was present in the lower limbs and titubation was absent. Spine examination was normal. There were no signs of meningeal irritation. Other system examination was normal. Summary of the examination. So there was slurring of speech present. She was having symmetrically reduced muscle bulk in the lower limbs and symmetrically reduced muscle power in both lower limbs. Bilaterally symmetrical hyporeflexia in the lower limbs, bilaterally symmetrical reduced sensations with signs of cerebellar involvement. There were no signs of meningeal irritation or cranial nerve involvement or autonomic dysfunction. So provisional diagnosis, a 55-year-old lady with insidious onset, gradually progressive bilateral ataxia and cerebellar signs of lower limbs with reduced motor and sensory sensation with no evidence of cranial nerve or autonomic involvement. The probable structures involved are cerebellum and peripheral neuropathy, and etiology is genetic. I would like to consider the possibility of degenerative spinocerebellar ataxia, possibly inherited because of family history positive.
Do we go ahead with the questions now or?
Yes, Deepti, you can start asking. Yeah.
Yeah. So you showed us a pedigree chart, right? Can you go back to that?
Yeah.
Or it's so what is this type of inheritance you're trying to portray here?
Here it portrays an autosomal recessive type of inheritance, but because the father had died around the age of 50, so we cannot really get to know exactly if the father had that in him or not. So it could be autosomal dominant as well.
Okay. And what are the other types of inheritances you know of?
Apart from autosomal dominant, autosomal recessive, there are X-linked dominant, X-linked recessive, mitochondrial inheritance.
What is the specialty about mitochondrial inheritance disorders?
They are cytoplasmic inheritance. They have cytoplasmic inheritance. That is the disease that the mother will have that will be passed on to all of her children.
They're maternally derived diseases.
Yes, maternally derived.
So when you take the history, you get the disease if the mother has it and the children have, and the subsequent generations, only the girl child will pass on the disease.
Right.
And how do you differentiate between a cerebellar versus a sensory ataxia, since you are localizing here to cerebellar?
Yes, so in sensory ataxia, there would be like when she would be closing her eyes, that would lead to enhancement of ataxia. But I asked that on the history, so she did not tell anything about that.
Were you able to perform Romberg's in this case?
I was not able to perform Romberg's because it needs to stand and to perform, and then her power of the lower limbs were 3, so it could not be performed.
Okay, and any importance of not having a bowel bladder versus cranial nerve involvement? How does it help you narrow down the diagnosis?
So bowel bladder involvement would mean autonomic neuropathy.
No, I mean to ask if does spinocerebellar ataxia have a history of having a bladder involvement, or is it just cranial nerves and spinal cord involvement, or like peripheral nerve?
There are some types of spinocerebellar ataxias in which there are symptoms of autonomic neuropathy and Parkinson type disorders.
Okay.
So to narrow down in which type of spinocerebellar ataxia it is, it could help.
Okay. Okay. Fine. Anyone else can go ahead?
What general
Actually,
physical examination, what specific things you want to look in this patient?
In general physical examination, we would go for a head-to-toe examination. We would be looking for vitamin B12, vitamin B1 deficiency signs, and for the
What
signs.
are those?
So in vitamin B12 deficiency, we could see pallor for anemia, and then we could assess for any spots which would be present.
Specifically, you want to look for something related to pigmentation.
Yeah.
The vitamin B12 deficiency patients usually have an hyperpigmented knuckles.
Okay.
Okay. And B1 deficiency?
In a thiamine deficiency, I'm not sure about it.
Any other vitamin deficiency can cause
Vitamin
cerebellar
E
edema?
deficiency,
Okay. You want to see anything related to vitamin E?
wrinkling of the skin,
Okay.
dryness of the skin.
Mm-hmm. Okay. Apart from vitamin deficiencies,
For alcoholism, like signs of alcoholism, like Wernicke's encephalopathy. So we
was the patient alcoholic?
no, the patient did not say that she was alcoholic, but like we have to make sure about that on examination. So there were no jaundice or no
Oh, jaundice is a sign of liver damage. What are the
yes.
signs of chronic alcoholism or alcohol use disorder? Specifically related to alcoholism, but not related to the liver disease. There is something called as bilateral parotid enlargement with a temporal lobe, temporal area atrophy. So that is a sign of chronic alcoholism you want to look for. Okay.
Okay.
Go to your sensory examination, sensory system examination. So when you are summarizing, you are telling the reduced sensation, but you did not specify what sensations.
In summary, like all these sensations are reduced: fine touch, crude touch, vibration, pain, temperature, tactile localization, and 2-point discrimination all were reduced bilaterally, lower limbs.
Okay, so what type of peripheral neuropathy you want to label it? This particular pattern, whether it was distal symmetrical, asymmetrical.
Symmetrical.
It was pretty symmetrical.
Yes.
Okay. So how will you perform Romberg's test?
In Romberg's test, we will tell the patient to stand and to place his hands forward, and then you will be supporting the patient from the sides as well as from the back. And then you ask the patient to close his eyes for 30 seconds, and we will see if the patient sways or he falls to the back.
Okay, first you will inform the patient, then you will ask the patient to stand with feet closed and also hands by the side of the body, not extending forward. Hands should be by the side of the body, and you should ask, or you should see the patient for the first 20 seconds with the eyes open.
Okay.
Then after 20 seconds, if patient does not sway, you should ask him to close the eyes, explaining the risk. Okay, and you should be there to catch him hold. So go for cerebellar examinations.
And sorry to interrupt, did you mention about joint position in your sensory examination?
Yeah.
That's
No,
important, right? You should.
Yeah, that's very important.
Okay.
Right?
Yes.
Why it is important?
For the dorsal column, the joint proprioception.
What are the two sensations carried by the dorsal column?
Vibration and joint proprioception.
With which tuning fork you check the vibration test?
126 Hertz.
Okay, how will you, if the examiner asks you to demonstrate for, how will you check for vibration sense? How will you demonstrate?
So we will start from the distal part of the limb, and we will place the tuning fork on the bony point of the joints. And first we will take consent of the patient. We will explain the patient how to perform the procedure. Then we will explain that the patient has to close his eyes, and he has to raise his hand if he feels for vibration. So we will then place the tuning fork on the bony prominence from distal most bony prominence, and we will move to the proximal part, and we will also miss some vibrations in between, so that to catch if the patient is saying the truth or not. And we will perform it bilaterally on the lower limbs or the upper limbs, wherever we are doing. We'll perform bilaterally.
So what you will inform the patient?
So we will inform that
what should patient indicate back to you?
Whenever he feels for vibration, he should raise his hands, or he should speak that I'm able to feel vibration.
And also, since we already demonstrated from a normal probable site, mainly the forehead or etc., so you should ask them to gauge the amplitude also. Okay, it is not just the presence or absence, it is also a graded response. How much compared to the normal area you are able to feel, and also the duration of the vibration. Okay.
Okay.
And what you could not perform in this patient as far as the cerebral signs are concerned? Was it nystagmus?
Gait could not be assessed.
Nystagmus was not there?
Yeah, the nystagmus was absent.
So what type of nystagmus, if at all, the patient has, you expect in a patient of cerebellum disorder?
It could be a horizontal nystagmus, or it could be a vertical nystagmus.
What is the most specific of cerebellar disease?
A horizontal nystagmus.
Okay, if this patient did not have these all reduced sensation, if his sensory system was normal, how would your diagnosis have changed or mattered? Still, you wanted to keep it as a spinocerebellar ataxia or something different?
I would still keep it as a spinocerebellar ataxia.
You don't have any other differentials. You're pretty in your presentation. It's evident that you're pretty sure that it's spinocerebellar ataxia. You don't have. At least you should provide some, at least 2 or 3 differential diagnoses.
Okay, so the differentials could be Friedrich's ataxia, because in the pedigree.
Yeah, I had a doubt. Go for a plantars.
Where?
Plantar reflex.
Plantars.
Yes.
Okay, was the plantar reflex normal?
Yeah, it was normal.
Okay. So how will you test for dysthyrokinesis?
Dysthyrokinesia, we will first take the consent of the patient. Then we will ask the patient we'll explain the patient what to do. So we will explain the patient that he has to first he has to perform this kind of movement and in a fast, and he does not have to stop in between.
Ask for repeated alternative movements. Okay.
Repeated alternative movements. Okay.
Okay. I will pass it to Akshay, sir.
Thank you. Samridhi, first of all, very good presentation. You have mentioned about some tests like 2-point discrimination, tactile localization. What are those?
So 2-point discrimination is we can keep a divider, and we can ask for from starting from the most sensitive point, that is our fingertips. We can start moving towards the distal part, and we can check for like at how much minimum distance the patient is able to appreciate that there are two different points, and when is he saying that it's just he can feel just one point, and we will be comparing it
Okay,
from
good. So
the
what does it tell you? What are you testing, or how does it help you to localize the lesion?
so in 2-point
Basically, what are
discrimination,
they?
we are checking for the dorsal column pathway.
What are these
Okay, have you
specific
heard of?
types of sensations? Tactile localization and 2-point discrimination. Where do you localize them?
In the dorsal column pathway.
Okay. So, have you heard of cortical sensations?
Yes, cortical sensations are the
Wha-
sensations that are felt at the cortex level.
Correct. So, what are the cortical sensations? So, the primary sensory cortex is in the post central gyrus area, no, parietal lobe.
Yes, yes.
So, what does it do? How can you check on examination? How can you check if the sensory cortex is intact or there's a lesion there? Okay, if you don't, no problem. Actually, what you have tested are cortical sensations. Those
Okay.
Akshay sir, some network issues there. Akshay
These
sir,
tactile localization and 2-point discrimination.
you're going to test them?
Yeah.
Sorry, ಕೇಳಿಸ್ತಾ ಇಲ್ವಾ?
ಇಲ್ಲ ಸರ್ ಕಟ್ ಆಗ್ತಿತ್ತು, ನೆಟ್ವರ್ಕ್ ಇಶ್ಯೂ ಇತ್ತು. ಇವಾಗ ಹೇಳಿ ಸರ್, ಕೇಳಿಸ್ತಿದೆ.
Sorry. Yeah. So Samridhi, I was saying, if your primary sensation is intact, only then you will think about testing for cortical sensations, because according to the pathway, sensory pathways,
Yeah.
unless your crude sensations are intact, your cortical sensations will not be perceived. So if your crude sensations are lost, you need not test for. I mean, there is no point of testing for cortical sensations. So you should keep that in mind. If your fine touch is lost, automatically no need to test for your cortical sensations. Okay. Can you tell us some possible causes, more common causes for cerebellar dysfunction? Okay. Before that, cerebellar dysfunction, what are the points in favor according to you in your patient? Why does the patient have cerebellar involvement?
So the points in favor are, I could show it somewhere. The points in favor are that first is there is a wide gate that was present, and there is imbalance.
Okay.
And
wide gate?
Yeah, a wide gate and imbalance, history of imbalance in.
Oh, you mean on history? In history, okay.
Yeah.
No, I meant on examination.
Okay. On examination, the heel to shin test is positive, and a rebound phenomenon is positive, where there was overshooting of the limbs that was present. Apart from that, there were slow saccades which were present. Loss of fast saccadic eye movement was present, and there were hypometric saccades that were present.
Okay, sir. 2 questions on management, please. We'll wind up. It's already more than 15 minutes now.
Got it. Hello?
Yeah. 2 questions on management, please.
Yeah. Got it. So, Samridhi, can you tell us what could be the common causes which you want to investigate first? Let's say she had only a cerebellar feature. What common causes would you want to look for in a patient who has cerebellar signs or cerebellar disease?
So we can do serum levels of vitamin B12, vitamin B1. We will do. Sorry.
What investigation would you first run?
Okay, so first the MRI or CT scan would be done. Then second, there would be genetic testing that would be done for the CAG repeats. Then third, we could do serum vitamin B12 levels, serum B1 levels, and vitamin E levels. Then we can do antibody testing for the paraneoplastic syndromes, and for the anti-glutamic acid GAD, anti-GAD, we can test for that. Then we can also test for any hyponatremia, like electrolyte imbalance that could be causing it, the electrolyte levels. Then we can check for the metabolic abnormalities, like the leukodystrophy.
Okay, Samridhi, how do you treat this condition? Let's wind up. Last question.
Okay. So spinocerebellar ataxia does not have any treatment. But like we do the investigations just to make sure if there is any treatable cause of the ataxia that is present.
Good.
So if we find that there is anti-GAD antibodies which are present, then we can just ask for to stop taking gluten. And if there are any like anti-gliadin, anti-endomycin antibodies for that, we can do that. So we are just
Okay.
checking if there is any.
Good.
Okay.
Okay, Samridhi.
We can go.
Yeah, it's a very well presentation, a very good presentation. But we can, I understand the mentor's problem also. Neurology cases, you can discuss the day long. But she is answering also really well. But due to time restrictions, we'll confine to time limit and ask only clinically relevant questions, not the theory aspects. Please request to the mentors. And thank you, Samruddhi. Thank you so much for that wonderful presentation. Second on, we have Miss Varshitha, who is a fourth year MBBS student from Government Medical College, Vellore. Varshitha, are you ready?
Yes, sir.
Yeah. Yeah, please make it full screen.
Is it visible, sir?
Yes, you can start.
Good evening, honorable judges and my friends. I'm Varshitha, and my case today is Mr. ABC, a 74-year-old male from Valaja, Tamil Nadu, who was previously a daily wage laborer. He's uneducated and belonging to lower middle class. He was examined on he was admitted on 4th of May and examined on the 9th of May. He presented with chief complaints of abdominal distension for the past 1 month and jaundice for the past 1 month. History of presenting illness. The patient was apparently normal before 1 month, after which he developed abdominal distension, which is insidious in onset, uniform in distribution, progressive, not associated with leg swelling or facial puffiness. It is associated with a history of abdominal pain for the past 1 month, insidious in onset, diffuse, progressive, sharp pain with no radiation, no aggravating or relieving factors. History of nausea and vomiting for the past 1 week, mostly after the consumption of food. It is not blood-stained. History of passing black tarry stools for the past 1 week, but no history of frank blood in stools. History of yellowish discoloration of the sclera for the past 1 month, with no history of high-colored urine, clay-colored stools, or intense itching. No history of epistaxis, gum bleeding, EC bruising. No history of breathlessness, palpitation, chest pain. No history of facial puffiness, decreased urine output, hematuria, frothy urine. No history of cough with sputum, fever. No history of EC fatigability. He has a history of loss of appetite with no significant history of weight loss. No history of altered sleep pattern or altered sensorium. The past history, no history of previous similar episodes. He has a history of hypertension diagnosed 1 year back, but he was not compliant to the medications. No history of diabetes mellitus, tuberculosis, ischemic heart disease, bronchial asthma, thyroid disorder. No history of blood transfusion, IV drug abuse, tattooing, or recent injections. No history of any significant previous admissions or previous surgery. Family history, no significant family history. Personal history, the patient consumes a mixed diet. However, his appetite has decreased since 1 month. Normal bladder habits, normal sleep pattern, history of alcohol abuse for past 50 years. He stopped consumption 1 month back. He consumes 7.2 units a day, which is 50.4 units a week. History of smoking for the past 50 years, 12 pack years. So the summary of history: a 74-year-old male presented with complaints of abdominal distension, jaundice, and abdominal pain for the past 1 month. History of nausea and vomiting, history of melena, history of easy fatigability and loss of appetite. He is a known hypertensive and a chronic alcoholic and smoker. His condition probably involves the GI system, in particular the hepatobiliary system. General examination. The patient is conscious, oriented to time, place, and person. He is moderately built and moderately nourished. He is afebrile. Only pallor and icterus were present. The rest were not significant. The vital signs are normal. On head-to-toe examination, no alopecia, medial supraciliary madarosis, no sunken eyes, bidot spots, subconjunctival hemorrhage, no parotid enlargement, no gynecomastia or pectoral muscle atrophy, no clubbing, no palmar erythema, dupuytren's contracture, no flapping tremors, and no leukonychia. Abdominal distension is present and dilated veins are seen over the abdomen, no testicular atrophy. On examination of oral cavity, the lips, gums appear normal. There is yellowish discoloration of the tongue and palate. No angular cheilitis and glossitis. Local examination of abdomen. Consent was taken and the patient was adequately exposed and examined under adequate lighting. Inspection. The abdomen is uniformly distended. The umbilicus appears to be in midline, everted and slit-like and shifted downward. Skin over the abdomen is normal. Evidence of paracentesis is seen. Dilated veins are seen on both sides of the lateral abdominal wall. All quadrants move equally with respiration, no visible peristalsis, no divarication of recti, hernial orifices are free. On palpation, the inspectory findings are confirmed. There is no local rise of temperature, no superficial tenderness, guarding, or rigidity. A diffuse deep tenderness is present. By dipping method, the liver is palpable 1 centimeter below the right costal margin along the mid-clavicular line. It is tender, firm in consistency, and has a sharp margin. The spleen is not palpable. The spino-umbilical distance is equal on both sides. The direction of flow in the veins is directed away from the umbilicus. The abdominal girth is 105 centimeters. Percussion. Upper border of liver dullness corresponds to the right sixth intercostal space along the mid-clavicular line, and the lower border could not be percussed due to ascites. The liver span could not be assessed. Shifting dullness is observed. On auscultation, normal bowel sounds were heard, no brewy, venous hum or rub. The systemic examination was also normal. Summary: a 74-year-old male patient from Valaja, Tamil Nadu, who was previously a daily wage laborer, presented with complaints of abdominal distension, jaundice, and abdominal pain for the past 1 month. History of nausea, vomiting, and melena. Known hypertensive and chronic alcoholic and smoker. On general physical examination, pallor and icterus was present. On examination of abdomen, there is the presence of ascites and distended veins. There is tender hepatomegaly and shifting dullness. The provisional diagnosis is a case of decompensated liver disease, probably due to a malignant etiology complicated by portal hypertension without hepatic encephalopathy. Thank you.
Dr. Deepti?
Yeah. So in this patient, since you told the patient has jaundice, right? So
Yes,
is it
ma'am.
common for cirrhotic patients to present with jaundice, or is it a like what stage of the illness does it present? You got my question, right? Do all patients of cirrhosis present to you with jaundice, or when
No,
does
ma'am. Jaundice is not a common presentation in cirrhotic patients.
So what is it a sign of? It's a sign of decompensation. So
Decompensation.
if you have
Okay.
decompensation, that is when a patient will present to you with jaundice. So even if
Yes,
the
ma'am.
patient has cirrhosis, the jaundice may not be clinically evident, right? So what are the 2 or 3 different types of jaundice you know of?
There is hemolytic jaundice
Mm-hmm.
due to hemolysis, and there is hepatic jaundice due to conditions involving the liver, the parenchymal liver diseases, and there's a post-hepatic jaundice due to obstructions.
Okay. And is there any clinical clue which will help you in differentiating the 3? Like based on the color of the jaundice or presence of some symptom which will help you narrow down the type cause of jaundice?
Based on the color of jaundice, if it's lemon yellow, we could think of hemolytic jaundice, ma'am.
Okay.
If it is a dark yellow, we could think of hepatic, and if it's greenish or yellow, we could think of a post-hepatic cause.
But then that any symptom which point towards a particular cause? Like obstructive jaundice, is there any particular symptom you look for or you ask for? Pruritus. Okay. Pruritus is a common
Yes, ma'am.
symptom, and it's more common with obstructive jaundice. And also, you should look at the color of the stools and the urine. So that
Yes, ma'am. High-colored urine and
differentiating the causes of jaundice. Okay. And how do you look for liver flaps or asterixis?
We ask the patient to extend their arms, and they have to flex their wrist at 90 degrees and spread out their fingers, and we will be able to observe there'll be a flapping movement, ma'am.
It is apart from hands, can you look for anywhere else?
Yes, ma'am, we can even look in the legs. We will ask the patient to make the patient lie down and flex the knees, and we will be holding the ankles, and we'll look for tremors in the knees, ma'am.
Is there any other name of asterixis you know of? It's also called a
flapping tremor.
Anything else? It's called negative myoclonus, if I'm not mistaken.
Yes.
Okay. Yeah, I think Dr. Rajashekhar can take over.
Come to your general physical examination. Varshitha, right?
Yes, sir.
How will you look for pallor?
We will be looking at the lower palpable conjunctiva, sir. And we can even look in the tongue, in the palm crease.
No, I meant how will you check? How will you say when the pallor is there or not?
When the sir, I didn't get your question, sir.
So remember, when you check for the pallor, you will see in lower palpable conjunctiva. Okay, lower palpable conjunctiva is divided into two parts. Okay, there is an inner part and there is an outer part.
Yes, sir.
Okay, so inner part is usually, excuse me, I'm sorry, the inner part is usually something called as the anterior rim or posterior rim. If I'm not sure the name, but they have, it has been divided into two parts, an anterior part and a posterior part. Okay, anterior part is usually attached to an eyelid. Posterior rim is usually attached to a sclera. Okay, and this anterior rim is usually very bright red in color, but posterior rim is little bit paler. When your anterior rim is pale compared to the posterior rim, that's where when you call pallor is present.
Okay, sir.
Okay. Is there any grading for pallor?
Yes. I don't
know. Where all you will check for the pallor?
You can look in the lower palpable conjunctiva, in the tongue, in the nail beds, and the palm crease.
Can there be anemia without pallor?
Sir?
Can there be anemia exist without pallor being evident on the general physical examination?
And vice versa also.
Yeah,
without pallor and pallor without anemia. Yeah, both.
These are famous Kundu questions, right? At least you should answer them.
I still remember my MBBS times.
Okay,
stock questions. These are the stock questions by any examiner.
Yeah.
And one more, what is very much highlighting here is it Varshitha, can you check for pallor when there is icterus is present? Because we enter
Yes, sir.
How?
So we will be looking at the upper bulbar conjunctiva for icterus, sir.
Oh, okay, but when the entire sclera has become this thing, icteric, how do you check for pallor? That
look at the other side.
yellowish hue will mask this paleness. Yes, what is the answer? Correct. Good. What is that?
We could look at the other sites.
Like what was that? Was the question by Raj. What are the other sites where you check for pallor?
We could look at the nail bed, sir.
Then
something more common. As soon as the patient walks into you, you tend to examine, right? The palmar creases.
Yes, ma'am.
Remember, for the undergraduates, these are the questions the examiner is going to ask you. They're not going. The question will never come to the diagnosis. Okay, the questions usually come how you demonstrate the examination findings. Okay, come to your examination, the systemic examination. Okay, there are few things missing here. Okay, the first and foremost thing, yeah, come to palpation.
Yes, sir.
Okay, the spleen is not palpable. How will you palpate for spleen?
So we will be making the patient lie in the supine position and with the knees flexed. We will be palpating from the right iliac fossa diagonally towards the left hypochondrium.
Mm-hmm.
And we will ask the patient to inhale each time.
Okay, what other methods you want to?
Since this patient has ascites, we'll be using the dipping method, sir.
This patient had ascites? You
Yes,
did
sir.
not mention your diagnosis. So I missed it. Ascites is not missing in your diagnosis. It's missing in your diagnosis, if at all, the final side. Okay.
Have you
Yes.
mentioned?
How will you check for liver span?
Liver span, we will have to percuss from top, sir, to look for liver dullness in the right
On
hypochondrium.
left side?
On right
On
side.
left side. Okay. So be very specific when you answer.
Yes, sir.
Yeah. What was the liver span in this patient?
So liver, I could not assess the liver span, sir, because of the presence of ascites.
How much ascites was there? For shifting dullness present?
Shifting dullness was present, sir.
How will you check for shifting dullness? Remember, at the time you mention shifting dullness is present, all examiners are going you to ask to demonstrate the shifting dullness. Okay.
Yes, sir.
Okay. How will you demonstrate shifting dullness?
Again, the patient is in supine position, and we will start percussing from the xiphisternum to the umbilicus, where there will be maximum tympanic node.
Before explaining any further, any abdomen examination, be it in the surgery department, be it in the medicine department, the instructions will be standard, and you are telling them correctly, except the bladder should be empty. All patients, the bladder should be empty. Okay.
Yes.
Okay.
So we will be percussing from the umbilicus. We will have to percuss laterally to one side, and we should not remove our finger, and we should ask the patient to turn to the opposite side from where we are percussing, and we should wait for at least 30 seconds, and we should again percuss. So once we will percuss till where we hear a dull note, and now the previous dull note will become resonant, sir.
Okay, then again you should ask the patient to go for the first position and then go back to the umbilicus area and prove that it is resonant. Okay.
Yes.
So you should complete it.
Are there any? Sorry.
Yeah, please go.
Are there
Please
any
go.
portal hypertension in your case? What you have seen? Like, have you mentioned about the presence or absence of portal hypertension?
Yes, ma'am. The patient had portal hypertension.
How do you say that on clinical examination or history? Like, what are the evidence of hypertension you've got?
In history, he had melena, ma'am. He had a history of passing black tarry stools, which could be due to an upper GI bleed due to portal hypertension. And we can also see he has anemia, probably due to the bleed. And he has dilated veins in the abdomen, lateral walls of the abdomen, ma'am.
What else you could have, I mean, if present, would have indicated in abdominal examination towards portal hypertension? Splenomegaly, right?
Yes.
So that spleen is not there. So you can say that absence of spleen may point toward against it, but it is not always necessary. So you may not have gotten it because the patient has a significant amount of ascites. If it would have been present, it would have been another evidence for you. Okay. And
Akshay, sir.
How will you demonstrate dilated veins?
Sir, the patient should be in the standing position, and we will be able to to this patient, it was visible on the lateral.
As soon as you tell that patient is standing position, that means you know how to demonstrate. Okay. Remember, that is the first answer that should come out from your mouth when they ask you to demonstrate the direction of veins. Patient should be standing. Most of the students go on demonstrating in the supine position. Okay.
Yes, sir.
Okay. Akshay, sir.
Yeah, Varshitha, well presented. So in terms of investigations, one question I would want to ask is, okay, what investigation would you want to run in the ascitic fluid?
The ascitic fluid, sir, the ascitic fluid protein albumin level, and then
For what?
to look for the SAG values or serum albumin ascitic gradient.
Okay, good. So how will that help you?
We can check whether it's a transudative or an exudative ascites, sir.
Not entirely correct. What are you looking for? But what is the terminology?
Like a higher SAG.
Correct. So SAG, what is the value? Cutoff value?
1.1 gram per deciliter.
Correct. So if it is 1.1 or more, it indicates not transudative exudative. What does it indicate?
If it's more than 1.1, it indicates a transudative, sir. Which could be
No. In nephrotic syndrome, you get a transudative ascites with low SAG. So the SAG is not to distinguish between transudative exudative. It's to distinguish between portal hypertension related ascites versus the others. So if it is 1.1 or more, then it is portal hypertension related ascites. So like I said, in nephrotic syndrome, it's not portal hypertension related. So the SAG will be low SAG ascites. Okay. You have mentioned malignant in your diagnosis.
Yes, sir.
So what investigation would you want to do?
Sir, I would like to check for the serum alpha fetoproteins to rule out, which could be increased in case of a hepatocellular carcinoma.
Okay.
And then I would like to do a ultrasound abdomen.
Okay. Ultrasound, if your alpha fetoprotein comes high,
Yes, sir.
would you want to go with ultrasound or something else?
Liver biopsy.
Sorry. Yeah. What would you want to do?
A liver biopsy, sir.
Liver biopsy. So that's riddled with difficulties. There's ascites. Probably the INR would be high, so coagulopathy will be there. They may even be pancytopenia with hypersplenism. So that means thrombocytopenia. So risk of bleeding. Any other radiological test for liver?
Contrast enhanced CT or just a CT. So.
What specific CT for the liver? For HCC? CCT is correct, but you have to add one more.
Yeah, there.
No.
Contrast enhancement.
Yeah, there is a specific pattern how you have this contrast enhancement.
It happens in steps.
I don't know, sir.
Single, double, triple, quadruple.
It's called triple phase CT.
Okay.
Yeah. And so when there's melena, now all that will go out of the window. What is the first thing you have to do?
First, we could go for endoscopy, sir.
So you have to stabilize the patient first. So CABs, make sure the patient is stable. What do you want to do before the endoscopy?
We could.
You want to look for
complete blood count and electrolytes.
Correct. So based on that, what you will do?
If required, we could go for a blood transfusion or.
Correct. Correct. So once stabilized, you do the endoscopy. Then what are you expecting in that?
We could look for esophageal varices or gastric varices.
Correct. So you found them. What to do next?
One, we could give medications to reduce the portal pressure, like terlipressin.
Okay.
We could also.
Once you visualize the varices on endoscopy, medical management takes a back seat. You have done the endoscopy, you're there. You can visualize the varices. What do you want to do to those varices?
We could go for sclerotherapy or band ligation.
Correct. So terlipressin, you can. Done from my side.
Just last one more thing. When abdominal pain is present, I think one more thing you should look for is spontaneous bacterial peritonitis. Okay, so that's one thing you should comment on, because when you that's a common cause for decompensation in CLD patients. So when you do the ascitic fluid tapping, you should always look for evidence of infection. That is one more reason to look for exudative versus transudative. Okay,
Yes, ma'am.
that should be fine. Is that okay? I think we'll go.
Yeah. Varshitha,
Yeah,
wonderful presentation. You answered really well. Next up, we have Miss Trisha Halder, who is a third year MBBS student from Medical College, Kolkata. Trisha, are you ready?
Yes, sir.
You can start.
Go ahead, skip the non-important slides, tell the important things, okay?
So good evening, everyone. We have, excuse me.
Click on the center first. Click on the center of the screen. Yeah. Click on the center. Then it will move slides.
So good evening, everyone. So we have a 30 years old Hindu male farmer presenting with the complaints of breathlessness on walking for 2 years, palpitations for 6 months, and repeated attacks of cough with expectoration. The patient was apparently well 2 years back when he noticed breathlessness on exertion, which is NYHA class 2, which gradually increased, and now he feels breathless in routine activities, that is NYHA class 3. He also complained of palpitations on exertion for 6 months. There is history of repeated attacks of cough expectoration. There is no history of hemoptysis or hematuria, orthopnea, paroxysmal nocturnal dyspnea, chest pain on exertion, and syncopal attacks. Regarding the cases, there is no history of edema of feet, abdominal distension, pain in right hypochondrium, nausea, vomiting, hoarseness of voice or dysphagia, fever and pain with petechial hemorrhages. And regarding etiology, there is no history of synovial spell, squatting episode, or exposure to venereal diseases with penile ulcer in childhood. However, in past history, there is history of fever with fleeting joint pain at 10 years of age. In treatment history, the patient had been to a doctor 1 year back, where he was given tablet digoxin. He took it for 5 months and stopped upon betterment. Personal history and family history has nothing significant. To summarize, a 30-year-old Hindu male farmer presented with complaints of breathlessness on walking for 2 years, which was insidious in onset and aggressive in nature. It was a grade 3 NYHS, a risk of left heart failure, but no edema present, so not congestive heart failure. He also complained of palpitations for 6 months. He also had repeated bouts of coughing with expectoration, but no hemoptysis. It suggests pulmonary congestion, and there is also a history of fever and fleeting joint pain in the past at 10 years of age, which is suggestive of rheumatic fever as a cause of the lesion. Thus, it can be a provisional diagnosis of valvular heart disease with pulmonary hypertension, mild heart failure, and right or left ventricular hypertrophy. In general examination, the jugular venous pulse showed large A waves, and jugular venous pressure was located 4 centimeter above the sternal angle, with all the other findings normal. Going to the examination of precordium, upon inspection, slight bulge was noticed on the precordium. Apex impulse was seen on left fifth intercostal space, 1 centimeter lateral to the mid-clavicular line. Pulsations were seen on the left second intercostal space. Upon palpation, apex beat was felt at left fifth intercostal space, 1 centimeter lateral to the mid-clavicular line, which was tapping in nature. Left parasternal heave was present. Diastolic thrill over the apical area was present when the patient is in left lateral position, and diastolic shock was seen was palpated over the pulmonary area. Upon percussion, left border is found to be 12 centimeter lateral to the mid-sternal line in the left fifth intercostal space, and dull note over second intercostal space. Upon auscultation, a loud S1 followed by opening snap, followed by low-pitched mid-diastolic murmur in apical area with pre-systolic accentuation, was found and loud P2 sound in pulmonary area was found. Other system examination did not reveal anything significant. So the provisional diagnosis is a rheumatic heart disease with mitral stenosis, pulmonary hypertension, right ventricular hypertrophy, and mild congestive heart failure with sinus.
Tell me the causes for breathlessness since 2 years. What all can be the possibilities when patient presents with breathlessness since 2 years?
So first of all, there can be pulmonary causes. In pulmonary causes, there can be pleural effusion, or it can be due to like pulmonary edema, or there can be lung consolidation. And in cardiac causes, there can be congestive heart failure, one cause, and there can be valvular heart diseases can be one cause, um, and also and also we have other causes like if there is increase in abdominal pressure can also be one cause of breathlessness.
Now remember, breathlessness since 2 years. Specifically since 2 years, I'm asking. Pleural effusion, lung consolidation. Very unlikely to present for since 2 years. Somebody has breathlessness since 2 years. What other pulmonary pathologies?
So, then it can be
Okay, what valvular diseases can present with breathlessness since 2 years?
so one is mitral stenosis, and then mitral incompetence. The and we have aortic regurgitation, and yes, these are like in.
What could be the reason for palpitations in your patient?
So the palpitations can be due to like any extra systole or during atrial contraction, or it can be due to ventricular tachycardia following a right or left ventricular hypertrophy.
Can you tell us some non-cardiac, non-pulmonary causes of breathlessness? Like since the question was on breathlessness before.
Non-cardiac and non-pulmonary causes.
Something which you encounter frequently and overlooked.
Okay.
If you don't know, just tell pass so that we go on to next question. Okay.
Yes, ma'am, I'll pass.
Anemia is one of the common cause, which is non-cardiac or non-pulmonary. Renal failure, where chronic kidney disease patients commonly present with breathlessness due to fluid overload. So these are two common causes which you should not miss. Okay. And what is the importance of parasternal heave? What does it indicate?
Ma'am, parasternal heave is a palpatory finding. Here, there is left parasternal heave. It most commonly indicates right ventricular hypertrophy. So when we are placing the ulnar border of our palm on the left border of the sternum, then we find a characteristic pulsation on the ulnar border is felt, which indicates that there is increased right ventricular activity, and this is more suggestive of right ventricular hypertrophy in this case.
How do you check for parasternal heave?
Ma'am, we place first of all, the patient is lying in supine position with the precordium exposed. Then we place the ulnar border of our hand. The examiner stands on the right side of the patient, places the ulnar border of the palm on the left side of the sternum, left border.
How should your hand be? Just if you can show in the camera, how should your hand be?
Ma'am, then if this one is the chest, then the hand should be like this.
Okay.
The ulnar border.
Okay.
And
Any other
then
method? Any other method?
I'm
Any
looking
other
for
method?
a common one. You place something like this, cocked up. It's called a.
Yeah, you should place your base of the wrist with the distal hand cocked upwards. Okay.
It's called cocked up wrist. So you place it like this. Okay.
okay.
That is more common. What you're telling, it's usually if you place a pen on inspection, that is where you place. You don't place your ulnar border of the hand. You usually place a pen on inspection to look, but on palpation, you place your cocked up wrist. Okay, not the ulnar border of your hand. Okay. And I think your auscultatory findings should be mentioned area-wise. What did you see in each particular area rather than telling them, like you can say in aortic area, pulmonary area, mitral area, and the other areas. You can just make a list and then present them. Okay. Because this is a pure cardiac case, right? You should focus more on the cardiac examination. Right?
Trisha, how will you check for pulse?
So for pulse, first of all, we will okay. The forearm, at the wrist, it is semi-flex and then the radial artery is felt at the styloid process by using the index finger to like stop the palpations coming from the proximal arterial circulation, and from with the ring finger we prevent the arterial pulsations from the palm of the hand, and with the middle finger we will uh, feel for the pulse. So on like while recording the radial pulse, we will look for the rate, the rhythm, the volume, the character, and then we will also look for radio-radial as well as radio-femoral delay by like recording the radial pulse on both the radial arteries, and then recording pulse on the one radial artery and on the femoral artery as well.
Okay, very good. For a third year MBBS, you have done a good job. Okay. Akshay sir.
Yeah, Trisha, again, well presented. So, how will you manage this patient?
So for management, first of all, in the investigation, I will go for first of all chest X-ray in the posterior anterior view, in the right anterior oblique view, and in the lateral view. Then I'll also go for echocardiography, which is like it is used specific for the diagnosis. Echocardiography, which is should be like transthoracic echo, it should be an echocardiography with color flow and using spectral Doppler imaging, which basically helps in measuring the valve pathology, the valve movement, and all the chambers of the heart. And we will also can investigate by catheterization to check the hemodynamic status of the patient, and then we can yeah.
Can you tell us the X-ray finding and one specific, one very commonly described finding on echo for mitral stenosis? So mitral stenosis X-ray findings, and on echo, one commonly used.
Excellent question.
So in X-ray finding, in PA view or the posterior anterior view, we will find the mitralization, that is straightening of the left border of the heart, and then we will also find the fan-shaped opacity called the pad swing sign, and then we will also find the dilated pulmonary arteries at the perihilar region. We will also find a shadow within shadow sign, that is the outer border is by the outer and upper border is due to left atrium, and the inner lower border is due to the right atrial shadow. And in right anterior oblique view, we will see the sickling of esophagus. We will do a barium swallow of esophagus as well. So it shows that the left atrial enlargement actually compresses the esophagus. And in lateral view, we will see the right ventricular hypertrophy. In echocardiography, the echocardiographic finding, I'm not able to remember right now.
No, it's correct if you say you want to just estimate the mitral valve area, the valve opening area. But then there's one commonly asked, commonly described finding, especially in quizzes.
Is it fish mouth appearance or? fish mouth or button.
Correct.
Fish.
Correct. Fish mouth. Yeah.
Fish.
Correct.
One
There's
small
one-
question. Sorry to interrupt, Doctor. I just wanted to know, since you mentioned that A waves are present in the JVP, right? Suppose tomorrow you see the patient in the clinic and you see that the A waves are suddenly absent. So what complication will you suspect has happened?
Atrial fibrillation.
Yeah. And why in a patient with MS you will get a left atrial enlargement?
Ma'am, because the mitral valve is stenosed, so the less blood will flow through the stenosed valve and more blood will remain in the left atrium. So that will cause both volume as well as pressure hypertrophy of the left atrium, and that is followed by dilatation of the left atrium. And finally, and that can also lead to left atrial failure when the disease advances. And
last chamber to get affected in a patient with mitral stenosis?
It is the right atrium.
And something else?
Right atrium.
Okay, I think we are overshooting time. I think I just want that's all I wanted to ask. I think we'll take over somebody.
Akshay, so yeah.
Do I have time to ask one question?
Yeah,
Gila?
definitely,
No,
sir.
no problem.
Definitely,
No
sir.
problem.
Definitely. Akshay, sir, please.
Is okay?
Yes, sir. Yes, sir.
Is okay? Yeah. So Trisha, if now she develops it, one last question. So if this patient with mitral stenosis develops atrial fibrillation, what are you worried about, and how will you treat that patient because of atrial fibrillation? Can you hear me?
Trisha, are you there?
Trisha?
Yes, yes, sir, I'm there. Hello?
So did you hear my question?
Yes, sir. So the last part, can you please repeat once?
Okay. So your patient with mitral stenosis, the JVP A wave disappeared, patient has developed atrial fibrillation. So how will you manage the patient?
I will manage the patient by giving diuretics and calcium channel blockers and also beta blockers. So as to suppress that uncoordinated, ineffective atrial contraction. Because if atrial fibrillation happens, then that can in backward effect, it can lead to left atrial failure, then also acute pulmonary edema, and that can be fatal for the patient.
Okay, Trisha, one specific question. If you are worried, I mean, you should be worried about the thromboembolic consequences of atrial fibrillation. Since this patient has mitral stenosis with atrial fibrillation, how would you, or what would you use? Which agent would you use to anticoagulate the patient? Last question.
I couldn't understand it. What anticoagulant am I using?
Which anticoagulant would you prefer using in this patient with mitral stenosis and atrial fibrillation?
Okay.
It's a valvular atrial fibrillation. No?
You can just tell us what anticoagulations you know of. What are the anticoagulants you know of? Then maybe we'll get an idea.
Yes, ma'am. We have the oral vitamin K antagonists like warfarin, sinucumulol, and then we have direct thrombin inhibitors like rivaroxaban, apixaban. Then we have
those will you use in valvular AF?
and we will actually prefer for non-vitamin K antagonists like these direct thrombin inhibitors, because if we use
No,
vitamin
it's the other way around.
The other way around. That was a trap. It's okay. It's okay.
Oh, well done. For third year undergrad.
I have a question to Trisha. You finished your DM cardiology and now doing MBBS, or what it is? How it is? Trisha, I want a specific answer. You are MBBS third year or DM cardiology third year? I want to know.
There is intern mocking us, saying you ask better MBBS questions.
No, I have a same question for the mentors also. I don't understand these students. Okay, what are they up to? In our time, it was not like this. Never. Okay.
Answering, we are going higher.
Goodness, she's the way she explained the
While
echo.
while I was an undergraduate, I
My
could not
goodness.
enter the examination only.
Goodness. This
This is the
is
only
too
thing.
good, too good. I'm getting goosebumps here
I'm
sitting,
impressed.
listening to her answers.
Certainly. Yeah.
Great.
So we should appreciate her interest in presenting the case being a
Exactly.
third. Very well done. Very well done.
Excellent. Okay. Next up, Aditya. Okay, next we have Mr. Nitish. Nitish Kumar. Yeah. Nitish.
Yes, sir. I'm scanning. I'm screening my PowerPoint. So just a second. Some glitches happened. Yeah.
It's a CNS case. Okay. Don't take too much
Yes, sir.
time. Tell the important
Yeah,
bits.
yes, sir.
Okay.
Yes, sir. Shall I start?
Yeah.
Yeah. Good evening, sir. This is Nitish Kumar, final year MBBS from Sri Mugambika Institute of Medical Sciences, Kanyakumari. So here is our patient, 70-year-old female, Terasammal, who's a retired cashew factory worker, came to our OPD with the chief complaints of neck pain and weakness of right upper limb and lower limb for past 14 days. Coming to the history of presenting illness, she was apparently well 2 weeks back. Then, on awakening from sleep in the morning, she felt severe neck pain, which was of acute onset, dull aching type, radiating down to the right upper limb, and the pain aggravated on the movement of neck, cough, or sneezing. Further, she also noticed that she couldn't move her right upper limb at all since waking up, due to which she had to use her left hand to feed herself or pick up the objects. And she also felt weakness on her right lower limb, due to which she could not walk with support. And the patient gave the history of difficulty of maneuvering right foot into chapels, dragging of right foot while walking, buckling of right knee, and difficulty in getting up from the squatting position. And coming to the weakness, it was progressive throughout the day. And upon waking up the next day, that is 13 days back, she noticed that her weakness of right lower limb has further increased, and her right upper limb weakness remained static, and her neck pain has not improved. So she was carried to the hospital. She also gave history of difficulty in getting from the bed and difficulty in turning side to side by this time. Coming to the negative history, there was no relevant history suggestive of any higher mental function involvement or cranial nerve involvement, sensory disturbances, or any bowel bladder involvement, or any cerebellar involvement. Then upon asking other histories, she had low-grade fever with evening rise of temperature. She reported loss of weight of almost 5 to 6 kgs in the past 1 month and loss of appetite. Importantly, there was no history of any trauma to the back or any weightlifting. This is about the negative history and positive history. Coming to the past history, she is a known valvular heart disease patient who was operated 12 years ago, and she is on her anticoagulants. She is also diabetic since 6 years on regular medications, had history of CAD, did her cataract surgery 2 years back. Other than that, she had no history of hypertension, COPD, CKD, and CVA. And personal history, she consumes a mixed diet, her sleep is adequate, bowel bladder is normal, no addiction or habituation. There is no history suggestive in family, and she is married with 4 kids. All are healthy. She attained her menopause, and there is no history of any psychiatric illness. So, coming to the summary of the history part, this 70-year-old lady who is a known diabetic with a history of CAD, who has undergone a valvular heart surgery on anticoagulants, currently presented to the OPD with acute onset of severe neck pain, which was radiating down to the lateral aspect of right upper limb, to the right fingers, which was of dull aching type, aggravated on cough, sneezing, and movements. She also had history of low-grade evening rise of temperature, loss of weight for past 1 month, and no history of trauma to back and neck. So this is a case of acute onset of hemiparesis on right side, with acute onset of neck pain, with a normal mentation, without any cranial nerve or involuntary movements or seizures. So from the summary, this is a probable diagnosis of spinal hemiparesis of human type. So let's go to the examination part.
Please stop.
Yes.
Drug history.
Yes.
No, you missed drug history on anticoagulants and any other antiplatelets.
No, sir.
She was only on anticoagulant.
Yes, sir.
Okay, if any patient is on anticoagulant, what advice usually they will get from the treating doctor? What blood test is to
INR.
get?
We have to check the INR repeatedly, sir.
Was she advised that?
Actually, this is the first time she is coming to this hospital. Her valvular heart disease has been, I mean, the heart surgery has been done in some other hospital, sir. So not sure whether she was on regular INR checkup or not.
Why is that important?
Because it can lead to bleeding. The clot may dislodge to anywhere, and it can produce like stroke, MI. And for example, if for this patient, if we want to do an neurosurgery, then our INR has to.
If her weight loss is significant, is weight loss significant?
Yes, sir.
Why do you say so?
Sir, when the weight loss is more than 10% in 1 month, then we call it as a significant weight loss.
That should have been the chief complaint, or no?
No, because she primarily came with an entire weakness of her right side. So,
okay, only on history,
not in a chief complaint.
Only on history. What? So you want to localize? Where you want to localize?
Sir, just from the history, it is involving a spinal cord, because all her other higher mental functions, cranial nerves are intact, and
Where
she
is
had
the
a neck pain. Lemmerite sign was positive because on movement, everything she had pain. It was aggravated. Sir, I would localize somewhere to the cervical region.
No. Where in the spinal canal actually? Inside the spinal cord, it is intradural, extradural.
Sir, it is extradural.
Why do you say so?
Because of the arrangement of fibers, the first affected is the upper limb, which she had weakness first here. So
no. What is the typical symptom of your patient that is taking you to the extradural side?
Sir, I didn't get you. Can you repeat it once more?
No. When you're saying extradural, what is the typical sign of extradural lesion that you usually get, and that your patient has?
Lemmerite sign positive.
No. The Lemmerite sign is actually a sign of spinal cord. Okay. It's a sign of cord lesion. Extradural usually have radicular pain.
Yes, sir.
Does the patient has radicular type of pain?
Yes, sir. It is actually, our pain is radiating to the limbs, which is over.
Which
she's having.
Which dermatome? Clinical.
Sir, C4. The
okay.
C4 dermatome.
Examination.
Yes, sir. On general examination, patient is conscious, cooperative, oriented to time, place, person, and she is alert and attentive. In general examination, she had pallor and mild bilateral pitting pedal edema. Then no other findings were there. Even the neurocutaneous markers and external TB markers were negative. All her vitals are stable. Then coming to the nervous system examination, first her higher mental function. All her higher mental functions are intact. The only thing is, because of her weakness, she cannot write. So next cranial nerve examination, I'll fastly skip through because the patient cranial nerve examination, everything is intact and normal. So shall I skip through it?
Yeah.
Yeah. So next, coming to the motor system examination, first assessing the bulk of the muscle, both in upper limb and lower limb. Everything, both in opposite limbs, it was less than 1 centimeter difference. So there was no wasting in both upper limb and lower limb. But coming to the tone, on the right side, it was hypertonia. On the left side, it was a normal tone. Coming to the power, on right side, she has complete hemiplegia of grade 0/5, and her finger grip is 0% on the right side, and its left side, it is completely normal. So lower limb also it is same. She had grade 0/5 of power, and on the left side 5/5, and trunk weakness is present. Coming to the reflex, first the superficial reflex, she had absent abdominal reflex and extensor plantar on the right side, and the deep reflexes were exaggerated on the right side with absent biceps and supinator jerks. So on the left side, everything is normal. Anal reflex was not done because we couldn't turn the patient from side to side.
No problem.
Next, coming, sir.
No problem. Go ahead.
Yes, sir. So next is the sensory system examination. First, on the right side, all the posterior column sensations were lost. That is position sense, joint sense, vibration, fine touch was lost. But on the left side, it is intact. Coming to the spinothalamic sensation, it is exactly opposite. On the left side, our pain and temperature were reduced from C4 dermatome. On the right side, it is intact. So it is, I think it is a typing mistake. The cortical sensations on the right side is also lost. On left side, it is intact.
Okay.
Then our cerebellar, sir.
So you were there when we were discussing first case. That means, okay, go ahead.
Yes, yes sir. Coordination system, on the right side, because of the weakness, we couldn't assess, but on the left side, there was no coordination. Rebound phenomenon, tandem walking, and Romberg's gait couldn't be assessed because of our weakness. There was no any involuntary movements. And other systems were normal, examination findings were normal, except we had a murmur of prosthetic valve, which was heard in a mitral area.
Oh, there was a spinal tenderness you have mentioned, right? Very
Yes,
important.
Yeah. Sorry, sir, I didn't look now. Our spinal tenderness was noted at C5 to C6 level. And it also, when on the movement, it's still aggravated. So coming to the summary, this 70-year-old female patient, known diabetic with history of CAD with valvular heart surgery, came with complaints of severe neck pain and weakness of right upper limb and lower limb for past 14 days. And on the examination, it revealed that she had right-sided hemiplegia of grade 0/5 with hypertonia on right upper limbs and lower limbs, absent abdominal reflex and extensor plantar response on the right side, absent biceps reflex and supinator reflex on the right side with exaggerated deep tendon reflex on the right upper limb and lower limb, reduced pain and temperature sensation on the left side from C4 dermatome onwards, and loss of dorsal column sensations on the right side. So on making up the diagnostic formulation, it is a case of Brown-Sequard syndrome due to spinal cord hemisection. Likely of infectious etiology is tuberculosis, and level of lesion based on the examination. On examination finding, it is C5 to C6 level of spinal cord segment, and the structures involved are right corticospinal tract leading to right hemiplegia, right dorsal column leading to right-sided loss of vibration and proprioception, and left spinothalamic leading to a left-sided loss of pain and temperature. Thank you, sir. Hello, sir.
Yeah.
Hi, sir.
So come to your general physical examination.
Yes, sir.
How will you check for pedal edema?
First, the patient will be either in a supine position. Next, we press over the bony prominence for 10 to 15 seconds.
Where?
Sir, in the medial malleolus, either of the malleolus, medial or lateral malleolus.
Exactly over the malleolus you want to press.
Yes, sir.
No, it should be at least 4 centimeter above the medial malleolus. Okay.
Okay, sir.
How much pressure you are going to put?
Sir, in the means.
That means how much pressure you are going to put. You want to press, right? How much you
Yes,
want? How
sir.
deep you want to press? You should
Sir,
press
till we get a fitting.
So even in a patient who does not have pitching edema, you will press till they get. Okay, how will you check for the tone?
Okay, sir, tone first we will check each limb separately. That is by lifting, rolling, and by palpating it, sir.
Okay, Akshay sir.
Yeah, Nitish. So well presented.
Yes, sir.
How will you manage this patient in terms of investigations?
So investigation, since we are suspecting TB, either we perform first we perform a chest X-ray. If we are seeing a pulmonary activity, we go with it, or we take CBNAT and Montax test, or interferon gamma test, which is actually a blood test for TB. Then we also collect CSF fluid, analyze, and send it for CBNAT. Here, probably protein will be raised and lymphocyte will be rich. And we take
Okay,
an
good.
MRI of the spine to
Correct.
see any edema.
Correct. So interferon gamma release assays are for latent TB. Here you are suspecting clinical TB. So MON2 and
Montax
IGRA
test.
test. IGRA and MON2 test will not be applicable if you're thinking of clinically active tubercular disease.
Yes,
CSF is correct. And MRI is also, of course, correct. So in CSF, can you describe how the CSF picture would be if it is tuberculosis?
Yes,
Can you hear me?
Lymphocytic pleocytosis will be seen and protein will be elevated.
And glucose?
So glucose to be normal or either decreased.
Yeah, so it will be mildly reduced. It will not be
Yes,
as
sir.
low as in pyogenic meningitis.
Okay, sir. Yes,
You
sir.
expect reduction. And what else? If you keep the sample overnight, next morning when you come back, the CSF?
It will become turbid.
Yeah, so it will form a coagulum. It's called coagulum.
Yes, sir.
Cobweb coagulum.
Yes, sir.
And what about chloride level in CSF for TB meningitis?
Sir, usually we see a rise in chlorine level.
In TB meningitis?
Sir, we see a rise in chlorine level.
Okay.
You have mentioned no external TB markers in general examination.
Yes, sir.
What do you mean by those?
Sir, like the shagreen patches or ash of nodules,
No, not
which will
neural
be.
fitness markers. I am asking no external TB markers, and you have highlighted it.
Sir, the shag. Okay. Here, what I mentioned is about the shagreen patches, and if it is a prolonged TB, we get a chest deformity, asymmetrical movement of chest. Then, if it is a pot spine, spinal deformity, nothing was seen, sir.
Yeah, Nitish, Chagrin's patches and ash leaf macules, they're not for
neurocutaneous
tuberculosis,
markers.
What are they for? It's not for tuberculosis. Which disease? They are neurocutaneous markers. Like Rajashekhar sir said, no, they're neurocutaneous markers for
Yes,
which
yes,
disease?
So chagrin patches we get in TB meningitis. Not.
They're for tuberous sclerosis.
Oh, sorry, sir. I have confused it.
Maybe you wanted to say lupus vulgaris, scrofuloderma. These are the
Yes,
cutaneous
sir.
forms of tuberculosis, no? Erythema nodosum.
Yes,
These
sir.
are the cutaneous manifestations of tuberculosis. Maybe that's what you meant by external markers.
Yes, sir.
Dr. Deepti, if she's there.
Yeah, hi. Sorry, I cannot turn on my video for 2 minutes. Doctor, can you tell me 2 causes for upgoing plantar but absent reflexes? Is my voice clear?
Yes, ma'am. Yes, ma'am.
Yeah. So usually when you see upgoing plantar, what is the type of reflex you get? You got my question, right? I mean to ask you, where do you see combined UMN with LMN signs?
Okay, ma'am. At the level of transection of the spinal cord, we see both human and element features. Element
Okay,
features.
that any other cause you know of? What happens in B12 deficiency? What will you get? What happens to the ankle jerk? Specifically, if you see an upgoing plantar with an absent ankle jerk, what all will you suspect?
Some thiamine deficiency and folate deficiency and vitamin B12.
Yeah. Apart from that, any other hereditary causes, degenerative neurological causes? What happens in MND?
I'm not sure of that. Any extrapyramidal system affecting diseases?
No, not exactly extrapyramidal. So if in case of Friedreich's ataxia or in motor
Yes,
neuron
ma'am.
diseases, get an absent ankle jerk with an upgoing plantar.
Upgoing plantar.
Okay.
Yes, ma'am.
Yeah.
Yes, ma'am.
Yeah. I'll be online. Like I'm just stuck in middle of work. I'll just be there in 2 minutes. Okay.
Okay, ma'am.
Okay, if there are no questions, then we can go ahead. The next student.
One last question, if I can ask.
Yes, sir. Please,
Yes,
sir.
sir.
Please.
Nitish, what level would you expect the contralateral spinothalamic sensations to be lost? At the level of transection?
No, sir.
In Brown-Sequard syndrome?
No, sir. No, sir. Because the fibers, if we see the fibers of spinothalamic tract, all the lower limb fibers come and no. Yeah, I see from the same place, sir, because they cross at the same level.
Have you heard of tract of Lisieur? So contralateral spinothalamic sensation, second order neuron, it crosses over, but that crossover happens at 2 segments higher
2 segments
level.
above.
Yeah. So
Yes,
at the level of hemisection, the contralateral pain and temperature is still preserved. What is lost is 2 segments below that. So left side, in your case, left side, 2 segments below it will be lost.
Below.
Okay.
Yes, sir.
Okay, Nitish, well done.
Yes, sir.
We will go ahead to the next student, Akshay.
Yes, sir. Thank you, sir.
Who is next? Yeah.
Yes, sir. Is my screen visible, sir?
Yeah. Go ahead.
Now I'm starting. I'm presenting the case of Mrs. X, 60-year-old female, resident of Uttamnagar, Delhi, who is a pottery maker by occupation. She presented with the chief complaints of cough since 16 days and fever since 15 days. History of presenting illness. She was apparently well 16 days back when she started having dry cough, which was sudden in onset, non-progressive in nature. It is not associated with shortness of breath. No aggravating or relieving factors were present, and no diurnal or positional variation was seen. She also presented with high-grade fever, which started 15 days back, associated with chills and rigor, intermittent in nature, spiked 1 to 2 times a day, usually at night time. It was relieved on taking paracetamol. She visited a private practitioner 8 days back, where she was prescribed medications, probably paracetamol and antitussives. She then presented to the emergency 5 days back due to fever with chills and rigor associated with shortness of breath and was admitted to the medicine ward. There was no history of runny nose or nasal discharge, no history of hoarseness and voice, no history of shortness of breath, no history of constitutional symptoms like headache and malaise, no history of night sweats, weight loss, known TB contact, no history of swelling of feet or chest pain, no history of hemoptysis. Past history, she is a known case of diabetes mellitus since 14 years, hypertension since 8 years, and hypothyroidism since 7 years, for which she is on medication but non-compliant. She also has a history of similar episode of fever and cough for which she was hospitalized last year. There's no history of TB, asthma, or COPD. Personal history is normal bowel bladder and sleeping habits, normal appetite, takes mixed diet, no food allergy or drug history, no history of tobacco or alcohol consumption, has been menopausal for 10 years, no history of postmenopausal bleeding. Family history, there are no history of similar episodes in the family, no history of TB, asthma, COPD, or diabetes in the family. Summary, 60-year-old lady, known case of long-standing type 2 diabetes mellitus, hypertension, hypothyroidism, not controlled, presented with on and off fever with chills and rigor and dry cough, not associated with shortness of breath. History is suggestive of lower respiratory tract infection. I would like to confirm with respiratory examination. General examination, patient was conscious, cooperative, and oriented to time, place, and person. Her pulse rate was 90 beats per minute. It was regular, good volume, normal character, and there was no radioradial or radiofemoral delay. BP was 110 over 70 mm of Hg. It was taken in lying sitting position. Respiratory rate was 21 breaths per minute. It was abdominal thoracic type of breathing, no usage of accessory muscles. JVP was not elevated. JVP was not elevated. Temperature is afebrile. BMI is 29.14, which is obesity class 1 according to WHO South Asian guidelines. Physical examination was not significant. Upper respiratory
Please
tract
stop.
infections, nostrils were patent. Yes, sir.
Okay, before going to systemic examination, what was the type of fever in your patient?
She has intermittent high-grade fever.
What do you mean by intermittent fever?
It means the fever was not continuous. There was fever. There was a spike in fever, and then it fell to the baseline, and then rose again.
So, in your summary diagnosis, you have mentioned LRTI.
Yes, sir.
What LRTI she might have?
LRTIs, lower respiratory tract infections can be bronchiectasis, bronchitis.
Did you say bronchiectasis?
Yes, sir.
No, bronchiectasis is not an infection. Okay.
Yes.
What other?
Bronchitis,
Can
pneumonia,
it can be
tuberculosis.
bronchitis. Why it is not bronchitis? Or is it bronchitis?
Bronchitis is usually associated with with a lot of sputum.
Mm-hmm.
And here, in our case, we have dry cough.
So what LRTI she might have?
We can have pneumonia, tuberculosis, and
Okay, in a general physical examination, what are the vitals? What are the vitals? Tell me. If somebody asks you what are vitals,
yes, sir.
what are the vitals?
Well,
List the vitals.
Vitals, pulse rate, blood pressure, respiratory rate, jugular venous pressure, temperature, BMI.
All these are vitals?
Carrot. Yes, sir.
So vitals are named only four. One is pulse rate, blood pressure, respiratory rate, and temperature. What is the normal body temperature?
Yes, sir. Normal body temperature 98.6, below 99
Below 99.
degree Fahrenheit. Yes, sir.
So if somebody comes to you with an early morning temperature of 98.9, is it normal?
So the normal temperature varies for morning and evening. It is slightly
Okay.
higher. The normal temperature will be slightly higher in the evening.
So when do you say there is a fever?
Hmm. There were different cutoffs. I just cannot recall.
What is the difference between fever and hyperthermia?
Hypothermia. In fever, the hypothalamic set point is stable. In hypothermia, the hypothalamic checkpoint, hypothalamic normal state increases.
There is a reset in the hypothalamic set point.
Yes, sir.
Okay, go ahead with the systemic examination.
Upper respiratory tract, nostrils were patent.
Skip.
Nasal septum. Lower respiratory tract inspection, chest was elliptical in shape, spine central, subcostal angle was less than 90 degree, trachea was in midline, trail sign negative, apex beak was not visible, respiratory movement bilaterally symmetrical, no inspiratory intercostal retraction was seen, no visible pulsation, scar sinuses or drooping of shoulder was seen. Palpation, no tenderness was felt, trachea was in midline, apex could not be palpated, transverse diameter is 32 centimeter, AP diameter is 25 centimeter, chest expansion was 2 centimeter, which is decreased. Expansion of right and left hemithorax was 1 centimeter. Spinous scapular distance is 8 centimeter on both sides. Crinoacromial distance is 14 centimeter on both sides. Vocal phrenitis was increased and bilaterally symmetrical. History of there was no tenderness or rib crowding. On percussion, direct percussion over the clavicles, it was bilaterally symmetrical. Indirect percussion, bilaterally symmetrical at supraclavicular, infraclavicular, mammary, axillary, and infraaxillary and suprascapular areas. It was dull on percussion in the interscapular and infrascapular areas. There was no shifting dullness. Liver dullness was positive in the sixth intercostal space in the midclavicular line. On auscultation, normal bilateral vesicular breath sounds were heard in all the regions except interscapular and infrascapular areas where inspiratory postcrefts were heard. Vocal resonance increased and bilaterally symmetrical. Egophonia and whispering pectorality were positive. Systemic examination was normal. Provisional diagnosis, 60-year-old lady, known case of diabetes mellitus for 14 years, hypertension for 8 years, and hypothyroidism for 6 years, is having lower respiratory tract infection, most likely community-acquired pneumonia. My differentials were lobar, atypical, and tuberculosis.
How will you check for tactile phrenitis?
For tactile phrenitis, I'll ask the person to say something like one or 99, and then I'll put my hands, the ulnar border of my hands, perpendicular to the longitudinal axis of the body, and then check it. I'll do it with both. Uh, I'll check the symmetry and then whether there is increase in it or not.
What is tactile phrenitis?
Tactile phrenitis is when the vocal phrenitis is when I'm able to hear the sound, and tactile phrenitis is when the ulnar border of my hand can actually feel the person's speak the whatever the person is speaking, like 99 or 11. When I can palpate that, I call it tactile phrenitis, and when I can hear it, I call it vocal phlegmitis.
Okay, if somebody wants to define tactile phlegmitis, I would define like it's a vibration felt on the patient's chest during the low frequency vocalization. Okay, this is a standard
Yes.
definition. Remember,
Yes.
and uh, what will you ask the patient to say? One?
Say yes. I'll ask the patient to say one, one, one.
No. You should not use 99 or one, etc. You should use any word or any sound which is formed by combining two vowels in a single syllable. Okay, you should have two vowels. Okay, it's like Scooby Doo, it's like toy boat, boy oh boy. Okay, it should have at least two vowels in a single syllable. You cannot
Yes.
use a 99. 99 does not have two vowels in a single syllable. Remember this.
Yes.
So, what does your tactile phlegmitis finding in this patient?
Uh, tactile phlegmitis was increased in this patient.
Increased where?
Increased in the interscapular and infrascapular regions.
Which side?
It was increased on both the sides, laterally symmetrical.
What does an increased tactile phlegmitis say?
Increased tactile phlegmitis is seen in case of in case of consolidation or cavity, or whether somewhere where there is direct communication with the outside, like bronchopleural connection. Because sound can travel faster through the solid or dense medium than it travels.
So, does your
easily.
patient have consolidation in both the infrascapular area? You mean to say patient has bilateral lower zone consolidation?
Yes, sir.
That is missing in your diagnosis. You have not mentioned any pathology in your diagnosis. You have skipped it as an LRTI, probably due to community acquired pneumonia. You should have a pathological diagnosis in the final diagnosis, whether it is consolidation, whether it is pleural effusion, it is a pneumothorax, what you want to say.
Yes, sir.
And you have missed the examination. Where exactly you find those increased vocal phlegmitis, whispering pectoral egophony, where were they? They were their entire lung. It's very unlikely.
No, sir. It was present only in the inferior and interscapular regions.
Which side? Again.
It was present on both the sides.
Okay. Akshay sir, Deepti ma'am.
Yeah, Sanskriti.
Yes, sir.
Can you tell me what is the importance of curb 65?
Yes, sir. Curb 65 is used to whether the patient should be admitted or not. It has 5 components. C is confusion. U is blood urea nitrogen if it is more than 20 millimeters of deciliter. R is for respiratory rate more than 30 beats per minute, and B is if the systolic blood pressure is less than 90 and the diastolic is less than 50. And 65 is the age. If age is more than 65, then the person should be admitted.
Okay, no, the scores for
Scores,
what score OPD is enough, OPD based treatment is enough. For what score you admit but not to ICU? Beyond what score ICU is required?
Yes, sir. For scores of 0 to 1, OPD based treatment is enough. Scores 2 to 3, 2 and 3, inpatient treatment is enough, and then more than 3, the patient has to be admitted to the ICU.
Okay, rather it is for 0 it's OPD, for 1 and 2 it is inpatient but not ICU, 3 and beyond, 3, 4, 5 it's ICU. In terms of investigations, what investigation would you do for this patient?
I
with
would
your diagnosis?
suggest I would suggest in chest X-ray. Then
So in the chest X-ray, what findings? So in your exams, if you're asked, no, what investigations would you like to do?
yes,
You don't just say the name of the test. You say what finding we would look for in that test. So since you've said an X-ray, what X-ray finding would you be looking for?
on chest X-ray, I'll be looking for consolidation or infiltrates.
Okay,
Then
so consolidation would be like a pathology diagnosis. On the X-ray, radiologically, what would you look for? What would be there? If it's, let's say, if there is consolidation in the lung, on the X-ray, how would it appear?
there will be a patch of whitish zone.
Opacity. So avoid saying
Opacity,
whitish.
yes.
You say opacity or lucency when it's black or white in the X-ray. So
Yes.
will that opacity, if it is, let's say, consolidation, then will that opacity be uniform or non-uniform? Consolidation.
Sir, I'm not aware.
No problem. It will be uniform consolidation. In between, there will be something called some lucent streaks you may be able to see. Within that whiteness, you'll be seeing some dark lines. They're called air bronchograms. So air bronchograms with uniform opacities would suggest consolidation. Okay, no problem. Deepti, madam?
Yeah. So suppose when you're examining a patient, the hemithorax is dull, and you have three scenarios. So one, the trachea is in central, one trachea is pulled to the same side, and one trachea is pushed to the opposite side. So what are your differentials for the three? So first, if the percussion note is dull or impaired, and if the trachea is central, what will be your DD?
If trachea is central, my differentials will be COPD, asthma, pneumonia.
Unilateral. Pathology is unilateral, right? What will you think? If bilateral pathology, okay, agreed. In unilateral pathology and trachea is central. So what is the cause? Like in your case, right? You just presented. What is the tracheal position in you?
Tracheal position was in midline in my case.
Yeah, so
in
unilateral kill shift?
Consolidation. In case of consolidation, the trachea will be in midline. Even in case of COPD.
So you have a dull percussion note and trachea is pulled to the same side as the pathology. So what could be the cause? Or let's say impaired note.
The causes could be atelectasis, a collapsed lung.
Okay, other than that, fibrosis.
Fibrosis.
Okay. If the lung is pushed to the, if the trachea is pushed to the opposite side, then what could be the cause? And if the percussion note is dull?
It can be a case of pleural effusion.
Okay. Yeah. So you should remember that hemithorax examination is most important with respect to the tracheal position, right?
Yes.
And what was about the JVP in your patient? Was it elevated?
No, ma'am.
It was normal.
Yes.
And what is the importance of looking at pulse? How does pulse examination help you in this patient? What are the abnormalities you can get in a respiratory case?
In a respiratory case, pulse can be increased. Plus, if it is a case of severe pneumonia, it can be bounding type.
No, simple, like consolidation. So what are you expecting in your patient? You have narrowed down that it's LRTI, patient had fever. So what could it be? If the pulse rate you are expecting it to have?
I'm expecting it to increase the
for tachycardia, right?
Yes.
When you don't have that relative increase in pulse with a rise in temperature, can you name one or two conditions where you see that kind of scenario? Where the patient has fever, but you're not seeing that relative increase in heart rate. There's a term for it.
Relative bradycardia is the term.
Yeah. So, and what are the conditions you see that?
I cannot recall.
Yeah, okay. No problem. No problem. I think, are there any other questions or shall we move ahead?
One last question. Can you demonstrate the percussion on your table?
Yes, sir. We have a flexor finger, the middle finger of the dominant hand, and
No,
the
if it's
flexibility of
okay, I want you to demonstrate percussing on the table
yes,
you're sitting.
sir. Sir, I'm trying.
Is it possible?
Sir, I'm trying to. Sir, is it visible? So, is this visible?
No, your video is not visible. It's okay. It's okay.
Mm, Sir,
Yeah,
there
but
is
you should,
a
you should be able to demonstrate the percussion. That's what the examiner is going to ask you.
yes, sir.
Okay. And remember, you should always examine both sides simultaneously. When you percuss the right infraclavicular area, you're going to percuss the left infraclavicular area before going into other areas. Okay. Please remember that.
Yes, sir.
Okay. Thank you.
Mm.
Next student, if there are no questions.
Am I visible, sir? Am I visible, sir?
Yeah, slide is visible. Slide is visible.
Oh, just a second, sir. Hello. Yes, sir. Can I share my screen? Okay. I'm Anushka Ranjan, studying in third year in University of Perpetual Help System Delta. The case I'm presenting is about a 37-year-old male having a chief complaint of painful redness in both eyes for 2 weeks. The past history of patient says that the patient has been suffering from a Raynaud's phenomenon for 7 years, and all his fingers and toes are affected. There is no history of infections, trauma, or any cardiac comorbidities, but the patient suffers from a destructive lung disease known to be as in NSIP pattern, which was identified on further investigations. There is no history of joint pain, photosensitivity, or alopecia and fever. Moving on with the personal history, he does not have any significant lifestyle factors or addiction history. There is no known drug history as well, but the pulmonary function test revealed a restrictive pattern with functional vital capacity 59%, and the HRCT chest showed interstitial lung disease. There are no signs of pulmonary hypertension on ECG or echocardiography. Moving on with the physical examination, the patient is alert and conscious, oriented to time, place, and person. The vital signs, temperature was afebrile, pulse was normal, BP was in normal limits, respiratory rate was normal, and SpO2 was more than 95% on room air. No pallor, icterus, cyanosis, clubbing, or lymphadenopathy was present, and no pedal edema was observed. Skin and extremities, moderate skin tightening was present over face, fingers, and forearms. Microstomia was present with limited mouth opening. The modified Rodden score, skin score was 15 out of 51. There was digital ulcers present on the fingertips as well as peridactyly and telangiectasis over face and hands. Raynaud's phenomena with blanching and cyanosis on cold exposure was present. Musculoskeletal system, no synovitis or joint deformities were noticed, but there was full passive range of motion but restrictive active movement of fingers due to skin tightening. There was no muscle tenderness or weakness. Coming to the ocular examination, the visual acuity was 6 out of 6 in both eyes. Intraocular pressure was normal bilaterally. Conjunctiva was infected. Sclera was nodular scleritis noted bilaterally. It was focal, raised, and inflamed nodules were observed on the nasal sclera with prominent dilated, non-branching scleral and episcleral vessels. Cornea was clear, anterior chamber was quiet, lens was clear, but on fundus examination, there was no evidence of vasculitis, hemorrhages, or optic disc changes. The systemic investigations, inflammatory markers were such as ESR and CRP were elevated. ANA came out to be positive, and anti-SCL70 was equivocal. Anti-centromere antibody was negative, and there were other markers came out to be negative, such as anti-CCP, ANCA, VDRL, and HBsAg. For the pulmonary evaluation inspection, there was no use of accessory muscles, chest expansion mildly reduced bilaterally, palpation came out to be symmetric, percussion was normal, and during auscultation, fine and inspiratory crackles were observed. During cardiovascular system examination, heart sounds were normal, S1 and S2. There were no murmurs or gallops, no history, no sign of heart failure, no evidence of pulmonary hypertension on auscultation, or there were no peripheral signs as well. So my probable diagnosis is diffuse cutaneous systemic sclerosis with bilateral nodular scleritis.
Okay, I think your presentation was a little atypical from the others, the sequence and the flow of the symptoms. So nevertheless, just go back and go back to your first slide of past history where you have started from the past history, right? So what do you mean by Raynaud's phenomena? What history does the patient give you when he says Raynaud's phenomena?
Ma'am, during Raynaud's phenomena, the patient's peripheral parts, such as fingers and toes, due to the vasoconstriction there, it turns necrotic or cyanosis can be seen. It's one of the manifestations of scleroderma or can be seen in SLE as well.
What are the types of Raynaud's phenomena you know of, and is it reversible or no?
Diffuse cutaneous systemic sclerosis and limited
What are the types of Raynaud's phenomena? What are the types of scleroderma? I'm asking you, what are the types of Raynaud's phenomena?
I'm sorry. Primary and secondary. For the secondary Raynaud's phenomenon, it is associated with systemic disease as well. But in Raynaud's primary, it's usually there is no specific disease associated with it. But the most common is the primary one.
Okay, so how do you differentiate between the two? Is there any difference on history between the two? Primary, secondary, do you know of?
Yeah, primary can be can persist for longer period than the secondary one.
Which is more symmetrical in onset, primary or secondary? Like all fingers and toes getting involved simultaneously, is it more a sign of a primary Raynaud's or a secondary Raynaud's?
For the secondary Raynaud's phenomenon.
The secondary Raynaud's is asymmetric, primary is more symmetric. And what are the three typically described color changes of Raynaud's phenomena you know of? Like, how does the patient tell you the history? Usually, exposure, the hands turn. First color change to happen. No, first the hands turn.
Weren't white, paler, and then it turns to cyanotic color, which is mostly blue, and then hyperemic color such as red or pink.
Okay, correct. So usually the triphasic color needn't be there in all cases. If it's a secondary Raynaud's, it can just be biphasic, where the three color changes may not be seen as clearly, right? And then go to your next slide. What is the other negative history you should have asked for apart from joint pain, photosensitivity, and alopecia? Like, did the patient not complain about skin thickness in the history itself? Because that was a finding you have mentioned in examination.
Yes, the patient did, because the patient came with the patient's chief complaint was the eye symptom, the redness, painful eyes.
Yeah.
Yes,
Since you've
but
history here, you could have put a word about the skin thickness part also, right?
Right. Noticed.
And my main contention is with your final diagnosis. How are you justifying the diffuse cutaneous systemic sclerosis diagnosis here?
Yes, ma'am. Um, because of the inflammatory markers, especially
No,
we
go
during
history,
during
examination, then investigations. Don't jump to investigations first. Leave the ANA profile aside. First, go to your history. So, what are the features in history which are suggesting towards a scleroderma-like illness?
um for scleroderma-like illness, the patient has Raynaud's phenomenon. Firstly, so
What is
it
just
can be seen
enlist the
in
points. Right, just enlist the points. The next,
um and the
the
patient also have, said to be uh had pain in his joints and
told there
immobile.
is no pains, no? You told patient has no history of joint pains or alopecia or photosensitivity, right? That was a negative history you mentioned.
What I meant was joint mobility. The patient complained about uh, not having not full passive motion, full active motion.
Okay, okay. What else? So you mean to say skin thickening, right?
Yes,
I think Anushka, it's better if you divide your presentation into examination, the traditional way of how you say a history, examination, and investigation. Because since you have mixed up
right,
two, three, you're not able to go in a orderly fashion. So first, you should look at
right.
in history what are the features which are pointing towards a scleroderma suspicion. So first is the Raynaud's phenomena. Second is the presence of skin thickness. So what was this? Sorry, skin tightening. So till what extent did the skin tightening, till what extent was the skin tightening present? Was it
It
present in
was
the level of,
15. It
no,
was
no, you
15
don't
out of 50.
tell me MRSS score. Tell me what extent, till where was it involved?
Um, on the
I'm
skin tightening.
in this, so just let me know because rheumat is the specialty I like. So I might be overshooting in this. Please stop me in between, okay?
No, no, Anushka, ma'am is asking why it is a systemic sclerosis. Why not it's the mixed
Why?
connective tissue
Yeah,
disorder?
so
Why
you have
not
to
it's an STD?
say your diagnosis,
Yeah.
right? Why it is
Forget
sclerosis?
antibodies. Okay, antibodies does not come into the discussion here.
Right. Um,
Only clinical.
in diffuse, usually the peripheral aspects are involved, such as uh, extremities, such as fingers and toes, and the uh, lungs are involved in and usually the cutaneous part, such as skin tightening
No, no, no,
in the
no. In
peripheral
your
part.
patient, ma'am is asking in your patient that you have examined, where was the same skin thickness present? Whether it is there in
In
the
the
face, it
extreme,
was there in the
in the
hands, it was there in the forearm, where it is.
Mentioned MRSS. Go back to that slide.
sorry, ma'am.
Go back to the slide where you have written the skin thickness and MRSS, all that slide. Go to that slide. Yeah,
Yeah.
here. So yes, describe the extent till where it was. There is a reason why I'm asking the extent, right? So till where was the skin thickness?
The face, fingers, and forearms.
So what are the two variants? There is limited and diffuse. So how does the skin involvement differ between the two? In limited, where is the skin involvement, and diffuse, where is the skin involvement? This can be even in
Um,
limit. Just say this is limited systemic sclerosis. I will not say it is diffuse. How do you justify that?
in obviously skin tightness is present in both of these, but the onset is more gradual. The onset is more gradual in the diffuse, and trunk involvement is very rare, which is not mentioned. So that these are the points, such as there are no tendon friction rubs also, neither trunk.
Don't deviate. See, my question is clear. What is the extent of skin involvement in limited versus diffuse? So in limited, if the skin involvement is up to the level of elbow and up to the level of knee and face. So
Right.
if there is involvement proximal to the elbow, proximal to the knee, or if there is any chest or abdomen involvement, then it is diffuse. You got my point? So
Yes,
your
I
first
understand.
be what is the level at which the skin thickness is present. So that will mainly help you to differentiate between limited versus diffuse. A. And second, since you've mentioned about MRSS, in how many sites do you check MRSS? And how do you check?
Firstly, Firstly, the forearms and the arms, then chest, then abdomen, then thighs, then legs.
Totally, how many sites did you check for?
Sorry, there's 17 total sites, if I'm not mistaken.
Yes, yes.
Yeah, face is also involved.
Yes.
Back and posterior thighs and posterior legs.
Back part of MRSS?
Sorry.
Back is not counted in MRSS. It is face, chest, abdomen, arm, forearm, hands, fingers, thighs, knees, and foot. Okay?
Yes.
Back
Yes,
is
ma'am.
not there. How do you grade it? It is graded from 17. So you have to get 50. 17 sites would be?
Um, 0 to 3.
Actually, see, MRSS is not expected out of an undergraduate. Since you have written about it, I had to ask about it. You're not expected to know this. See, your whole idea should be to identify the diagnosis. You do not have to go over and beyond what is expected out of you. Okay. So it is mentioned, yeah, what you mentioned is correct, 0 to 3. So what does 0 mean or what does 3 mean?
The more the score is, the more skin tightening is present. So, 0 means less tightening. When we pinch, there is less skin in the hold, and the more the score is, the
I think you're getting it the other way around.
sorry, the more the score is, the more skin will be in the hold, and the lesser the score is, the lesser the skin will be in the pinch
How
hold.
pinch the skin between your thumb and index, okay? And see the pinchability of the skin. So if you're unable to pinch it completely, like you are not able to get any fold of skin in your two fingers, then it is 3. If you are able to pinch it fully, if you're able to get a good hold of the skin, like a normal elastic skin, then the score is 0. So then it is graded subjectively between 0 to 3. Okay?
Yes, ma'am.
Yeah. What do you mean by telangiectasias and where do you look for them?
Usually in the face, and uh, extremities such as hands.
Hands or palms? It should be palms specifically. Okay.
Yes.
How
Yes,
do you
ma'am.
check whether they're telangiectasia or no? How do you confirm? You use something? Or are they like, do they have some other specific character?
The During inspection, we might notice there are purple spots, and we look for them in oral mucosa as well,
Okay.
and in the palms and fingertips. Sorry, ma'am,
If
you
the
were not audible.
white, how do you know it's a telangiectasia?
Um,
You look at the blanchability. You press and see if it is
yes,
filling. Okay.
yes,
Yeah.
ma'am.
I'll leave it for other people to ask. Maybe I'll come back again when she comes to diagnosis.
Differential diagnosis for Raynaud's phenomenon. Why do you say it's Raynaud's?
Uh, I
I say
said
it's
so. It's
arthritis.
Raynaud's phenomenon is the patient's past history, sir. It's one of a symptom for diffuse cutaneous systemic sclerosis. Um, my other diagnosis, if I had to, my other differentials could be SLE and rheumatoid arthritis as well as GPA, which is um,
Common is Raynaud's and rheumatoid arthritis or GPA, Anushka.
SLE as well. And
Okay, actually, I agree. Something more closer to that, something mix of two diseases.
um, connective tissue disorders.
It's called, there's a term, it's called mixed connective tissue disease, MCTD.
Mixed keto, yes.
So
I
Raynaud's phenomenon is, yeah,
I
yes,
think
go.
there is a fundamental difference in the way case presented here, and
Yeah.
I think that's how they present the case in Philippines. So, uh, or maybe we are not used to this kind of presentation, or she is not used to our kind of presentation. That's the problem. Okay. So do you
Yeah.
usually get the investigations being available at the time of case presentations in your final exam?
Yes, sir. We are asked in examinations. We are usually asked multiple choice questions in which we have to solve um, many case studies, and sometimes they give us investigation, and sometimes they do not. Sometimes it's evident without it. So yeah, we are used to both of these
Okay,
things.
I will pass to Akshay, sir.
Yeah, Anushka, well presented, and maybe I would agree with the way it might be conducted there, because I think, frankly, we also should change the way we assess our students. We should shift from the traditional, old-fashioned methods to little more practice based. But all that aside, Anushka, I know you've read it, it's quite apparent you've read well about systemic sclerosis. Can you tell us can you tell us a few other antibodies? So anticentromere here was unequivocal. I'm sorry, equivocal. So
Yes,
any other antibodies you
anti-SCO-70
know?
was.
If you speak-
I know about ANCA, ANA, and anti-SPL, anti-centromere, anti-dsDNA, ANA, which is very prominent in autoimmune diseases.
No. In
Then
diffuse cutaneous systemic sclerosis. So since your topoisomerase antibody or SCL70
uh,
antibody here is equivocal, any other antibodies you know? of diffuse
ANA,
cutaneous? ANA is
ANA
like the screening
anti-natal.
test.
Yes, sir.
ANA would be the umbrella antibody under which different specific nuclear targets would be there.
Um, anti-RNA polymerase 3 and
Excellent.
anti-U3 RNP, anti-U3
Okay.
RNP.
Well done. Well done. Beyond your level, I think. Very well done. Okay. What is this NSIP? Can you tell us? This lady had NSIP in the lung, no?
SMID. Oh,
You mentioned,
NSIP. Yes,
yeah.
yes.
NSIP.
And non-specific interstitial pneumonia is what NSIP stands for. It's usually um, during a CT, during a high resolution CT, we can see base ground glass opacities in the basal lungs, um, which is seen in this case. Uh, and usually seen in sclerodermic diseases. Um, yes,
Okay. So very good.
it's
One last question. Suppose now I give this lady steroids, a high dose of steroids, thinking that should take care
right.
of her symptoms, her scleritis and all that. What complication should I be looking for, especially considering she's
Steroid,
diffuse cutaneous?
so steroids can make the patient more dependable and um, on usually, and it can be an overload on. It can also reduce immune function. The patient becomes more vulnerable to infections, um,
That's correct.
as well
That's
as
correct. So specifically for a diffuse cutaneous systemic sclerosis patient, so there are it's
SRS.
systemic sclerosis. No? There are systems involved. So one is lung in her. So what are the other systems you're looking
Yes.
for?
Sir, kidney is involved.
What?
Sclerodermic renal crisis is one of
Correct.
the manifestations for severe scleroderma.
So how do you treat that?
Mm,
If she ends up having scleroderma renal
uh,
crisis, drug of
then
choice would.
in sclerodermic renal crisis, there is renal hypertension. So we'll choose ACE inhibitors to manage that, and immunosuppress um, high dose
Inhibitors.
Good job.
steroids. Yeah, sorry.
You're talking
Good job.
Steroids are usually avoided.
Yeah.
Yes.
And can you give for the Raynaud's phenomena, Anushka? Last question. What will you give to treat the Raynaud's phenomena?
For the Raynaud's phenomena, for the pain, I would suggest NSAIDs, and for also some tocilizumab and rituximab are there, and the mostly for the first line drugs are nifedipine, which is a
Yes.
CCB, and other vasodilators can also be given, such as
Finally, you took the name of
nitroglycerin.
doctors.
Yes. Yes, that's fine.
Sorry,
Okay.
sir.
Yeah.
Thank you, ma'am.
Next student.
Is that audible, sir? Yes, sir. So my patient name. Is it audible, sir?
Yeah. Please go ahead. Make it fast.
Mr. ABC of 38 years old male, Hindu by religion, 12th standard, from Katpadi, Vellore, Kuli by occupation. The date of admission is 2/5, and then date of examination is 5/5. The patient came with the chief complaints of abdominal distension for past 15 days, swelling of lower limbs for past 12 days, yellowish discolorization of eyes for past 12 days. History of presenting illness. The patient was apparently normal before 15 days, after which he developed abdominal distension, which was insidious in onset, gradually progressive, uniformly distended abdomen. The distension of abdomen changes the position, no aggravating and relieving factors, not associated with breathlessness. Abdominal distension was not associated with abdominal pain. Swelling of lower limbs present since 12 days, which is insidious in onset, gradually progressive, initially around the ankle and currently progressed to the thighs, no diurnal variation. No aggravating and relieving factors. Patient presented with yellowish discolorization of eyes since 12 days, insidious in onset, noticed by his wife, which is non-progressive. No history of generalized itching, no history of clay-colored stools, no history of high-colored urine. No history of fever, no history of pain abdomen, no history of blood in vomit and blood in stools, no history of black tarry stools, no history of breathlessness, no history of diarrhea, constipation, no history of involuntary movements, altered sensorium, and changes in sleep pattern. No history of decreased appetite and weight loss. No history of breathlessness, chest pain, palpitation. No history of orthopnea and PND. No history of decreased urine output. No history of puffiness of face. No history of cough with sputum, evening rise of temperature or night sweats. Past history, he had a similar complaints of abdominal distension and yellowish discolorization of eyes 10 months back, which is persisted for 15 days and was treated for same and relieved with symptoms. No history of diabetes, hypertension, asthma, TB, epilepsy, and ischemic heart disease. No history of tattoo, piercing, no history of blood transfusion, no history of past surgical intervention. Personal history. He consumes mixed diet, normal appetite, normal sleep pattern, regular bowel and bladder habits. He had an addictive habits of he consumes alcohol since 20 years, whiskey 180 ml per day, which is 7.2 units per day. No history of smoking, no history of IV drug abuse. A family history, no relevant family history. A summary, a 38 years old male, a known alcoholic for past 20 years, presented with abdominal distension for 15 days and swelling of lower limbs for 12 days and yellowish discolorization of eyes. It involves the hepatobiliary system, and my probable diagnosis, decompensated liver disease, and probable etiology is alcohol consumption.
Stop,
General
please stop.
physical.
So what is the cause of abdominal distension in your patient?
Sir, alcohol consumption, sir.
Alcohol consumption causes abdominal distension.
Sir, due to ascites, sir.
Why do you say it is
alcohol,
ascites?
Due to decreased hypoalbuminemia.
No. Why do you say no? I'm not asking you the causes of ascites. I'm asking you, why do you say this abdominal distension in your patient is due to ascites? I would say it is due to some tumor.
Sir, I can rule out other etiology for tumors, sir. No other etiology for that, sir.
On history, what is a very definite sign that your patient's abdominal distension is due to fluid?
Sir?
Okay, what are the causes of abdominal distension?
So it is platters, fluid, or fat, fetus, or any malignancy, or
So
a
can
fluid
it be a
bladder.
fetus in your patient?
Sir, no, sir. It in females it is
So can it be a flatus?
no, sir. It is a fluid,
Why?
sir.
Since
Sir?
it is 2 weeks, it is not flatus.
No, sir. He has a past history of a similar complaints, sir. So chronic alcoholism with past history.
Was there fluid being tapped in the past?
No, sir. No fluid tap was done, sir. Only medications was given.
Okay, go ahead with the examination.
So general physical examination, the patient consent was taken. Patient is well and nourished. Patient was conscious, cooperative, oriented to time, place, and person. Patient was examined under adequate light and exposure. The pallor is present, icterus is present, cyanosis absent, clubbing absent, lymphadenopathy absent. Edema is present in lower limbs till knees, which is spitting time, and it is fast filling. Vitals, pulse 68 beats per minute, which is normal in rate, rhythm, character, volume. Delays are present, no delays are present. Blood pressure 110 bar 80 mm of HG measured in right arm, sitting position. Respiratory rate 18 breaths per minute, regular, thoraco-abdominal. Temperature air febrile, JVP not elevated. Head to toe examination, no alopecia, no bite spots, no case of flazaring, no xanthidisma, no parotid enlargement, no spider nevi, no fetus hepaticus, no palmar erythema, dupuytren contracture, the nails are normal, no flapping tremors, no gynecomastia.
Okay, go ahead. Skip.
Systemic examination, oral cavity examination is normal. On abdominal examination, the patient consent was taken and examined under adequate exposure. Inspection of supine position with the knees and hip flexed. Abdominal is uniformly distended. Skin is stretched and shiny. The flanks are full. Umbilicus is aborted. No dilated veins. Corresponding quadrants moves equally with respiration. No scars and sinus. No visible mass. No visible pulsation. No visible peristalsis. No diversion of peptide. No cough impulse for hernial orifice. No scratch marks. No dilated veins on standing position. Palpation, which is done in supine position with both lower limbs flexed. On superficial palpation, no local rise of temperature, no tenderness, no guarding or rigidity. Deep palpation, liver is palpable by dipping method, 4 cm below the right costal margin, which is prim in consistency. Edges are round, nodular surface, and non-tender, and it is non-pulsatile. The spleen is non-palpable. Measurements, abdominal width of 108 centimeter. The sternum to umbilicus, it is 39 centimeter. Umbilicus to pubic symphysis, it is 24 centimeter. So the ratio is 1.625. Umbilicus to anterior superior iliac spine is equal on both sides. On percussion, liver dullness, upper border of the liver dullness is in 5th intercostal space in right mid-clavicular line. The lower border could not be percussed. Spleen dullness by Castle method, but could not be percussed. Shifting dullness is present. On auscultation, normal vowel sounds are here. No venous hum, no bruise, no friction rub, no suction splash. Parectal examination is normal. On systemic examination, no other systemic examination suggestive of this. No relevant history. Professional diagnosis, a 38 years old male with a history of consumption of alcohol since 20 years with abdominal distension, swelling of lower limbs, and yellowish discolorization of eyes, suggestive of liver pathology. The likely cause is chronic alcohol consumption. My probable diagnosis is decompensated chronic liver disease with ascites, with no future suggestive of other complications. Thank you, sir.
Akshay, sir.
Okay, Arunaa, nice presentation. So in your LFTs, if you ask for LFT in this patient, what clues are you looking for to implicate that he has ethanol consumption history?
Sir, amino enzyme levels, sir. Aspartate and alanine aminotransferase enzyme will be above 2, sir. So,
Which one would
in
be higher?
chronic, so AST level will be higher, sir. Aspartate aminotransferase.
Correct. Anything else?
The prothrombin time will be elevated, sir. Then
But that's not
gamma,
specific to ethanol, no? So ethanol, one is AST elevation being higher than
gamma glutamyl,
excellent. Correct. So isolated GGT elevation with normal ALP, alkaline phosphorus.
Yes.
Okay. And what other abnormalities you're looking for? Albumin, what will be there?
SAG ratio. Asking for SAG ratios.
No,
in
in
SAG
general.
ratio,
Okay, fine. SAG. You tell us about SAG.
sir, if you see the SAG ratio, if it is more than 1.1, it is due to portal hypertension. If it is less than that, we can rule out it is due to some other cause like pancreatitis, such things, sir. Also, it is used to differentiate transudate or exudate. In transudate, the value will be about 2.5, and exudate it will be less than 2.5.
No, what are you talking about? SAG more than 2.5, less than 2.5, or?
Not
The
SAG.
2.5
SAG is
value.
1.
Correct.
Albumin.
So 2.5 value is for albumin or protein.
Albumin.
So acidic fluid protein, if it is greater or lesser. Okay. So let's say your patient also has elevated test. You do your routine tests for this patient, and the patient's creatinine level is seen to be high. It's let's say it's seen to be 1.8 milligram per deciliter. So what will you infer from that?
So if the creatinine level is more than 1.5, it's suggestive of hepatorenal syndrome, sir.
Good.
There may be 2 types of hepatorenal syndrome based on the diagnostic criteria, type 1 and type 2, sir.
Okay. Can you tell us, do you know if there's been some updates to those terms? Is it type 1 or type 2 now? A couple of years back, there was an update. It's not called type 1, type 2. It's called HRS, AKI and non-AKI. So, but
acute.
Essentially, yeah, acute kidney injury and non-acute kidney injury. Essentially the same. So if suppose this HRS patient, what do you want to do? How would you manage if they develop an HRS?
We should give by therapeutic management should be done, sir, for acute kidney injury, sir, because it may be due to infections.
Okay, so you treat the infection, but otherwise for HRS, any treatments, any agents, pharmacological agents?
I'm not sure about this.
Okay, so either you can use terlipressin, which is a V1 receptor agonist, or you can use midodrine, something which promotes alpha agonism. So alpha 1, like midodrine, or you can even use norepinephrine. But you should also try albumin. So you should give albumin infusions to see if you can increase or you can expand the intravascular volume and improve the renal perfusion. HRS is what kind of renal injury? Is it pre-renal, renal, post-renal?
Pre-renal injury.
Pre-renal, excellent.
One last question, Anna. In this patient, what are the common precipitating factors for hepatic encephalopathy if you encounter? Like what you should be aware of in the patient?
We should aware of its sleep patterns, ma'am. Because altered sleep pattern is one of the visible clinical feature we can go for hepatic encephalopathy. Then
No, I mean to say, what can precipitate hepatic encephalopathy, or what can cause a sudden decompensation in these kind of patients?
um, um,
There are a few conditions, right? Like excessive diuretic use, or you know, hypokalemia, or spontaneous bacterial peritonitis, melena.
complications.
Okay, so those kind of things can precipitate. So you should be looking out for those complications so that you don't push the patient further. So how will you, what are the common drugs you use in management of hepatic encephalopathy?
Um, um, Antipsychotic drugs, ma'am.
Before that, like how will you manage? A patient has come to you with hepatic encephalopathy, you are in internship now, and what will the medications you will advise, or what are the, therapeutic you will offer to the patient?
For treating, first we should treat the underlying cause. If portal hypertension is present, we should treat with the non-selective beta blockers like propranolol, ma'am.
The patient is in NSEF still? So you usually give enema like a lactic enema, then you give rifaximin, right? Okay, fine. You read about that. That's no problem. That's from my side. If there's anything else, or we can go for the next case.
Okay, next student can take up the next student.
Yeah, I think it's already 9.
Isn't Arunaa the last one? Seven. Okay. Okay.
Gautam, are you there?
Yes, sir, I'm there, sir. My connection is just lost and came back. Just a minute, sir. I'll be sharing my screen. Yes, sir. Yes, sir. Sir, can I share through the mobile itself? The same data. అది కాదు అవసరం. Yes, sir. Yes, sir. Yes, sir. Done, sir. Done, sir. Yes, sir. Uh, Good evening. I'm going to present the case of yes, sorry for the delay. Good evening. I'm going to present the case of a patient named XYZ who is 34 years of age. He's male and he works as an employee in the laborer in the rice mill, and his education is 10th standard, and he hails from Kottu. He informant is self and mother as a secondary informant. Coming to the chief complaint, he complains of cough with expectoration since 20 days and breathlessness since 20 days. Bilateral lower limb swelling since 7 days. Coming to history of presenting illness, the patient was apparently normal 20 days back. Then he complains of history of cough, which is insidious in onset and gradual in progression associated with expectoration since 20 days. Sputum is scanty in amount, yellowish, non-foul smelling, non-blood tinged. Cough aggravated during nighttime, not subsided on medication. No, and there is no history of fever and night sweats. No nasal discharge in postnasal drip, and no history of sore throat and cough not associated with wheezing, chest tightness, and previous history of similar complaint, and no history of any allergies. And there is no history of smoking, no history of heartburn and water brush, no history of medications such as ACE inhibitors, and no history of recent immobility due to long travel. And the patient has breathlessness since 20 days, which is insidious in onset and gradual in progression, which resulted now in slight limitation of ordinary physical activity. Complaints of difficulty in lying flat, experiences breathlessness within minutes on lying down, and keeps an extra pillow. That is, keeps 2 pillows for symptomatic relief. He does not complain of waking in the middle of the night due to breathlessness and walking to and fro or going to window for the fresh air. Does not complain of increased frequency of maturation during night, that is waking in the middle of the night. For it is not associated with chest pain and palpitations, not associated with loss of consciousness, does not improve upon bending forward, does not complain of breathless. There is no variations in the postural. There is no increase in or decrease in breathlessness with associated with posture. And he does not complain of increase in breathlessness during night or in cold weather. Does not complain of chest pain and increased sweating and palpitations. Does not complain of occupational exposure such as silica, asbestos, or coal dust. Does not complain of rash and joint pain. No history of fever, chest pain, breathlessness, joint pain moving from one joint to another, and dance-like movements of the limbs. And does not complain of weight loss, heat tolerance, and tremors and palpitations. Coming to limb swelling, complaints of bilateral lower limb swelling, which is insidious in onset and gradual in progression since 7 days, which aggravates on walking. There is no history of hypertension and diabetes in the past, no similar complaints in the past, and no significant surgical history. Coming to personal history, he has history of alcohol intake since 10 years, 1 quarter of whiskey per day. His mother contradicts his statement and says he drinks much more. He has history of chewing tobacco since 10 years. No history of smoking. He takes mixed diet, his sleep is reduced, appetite reduced, and gallbladder are appropriate. There are no similar complaints in the family. No family history of cardiac-related deaths or any history of diabetes and hypertension. He is currently not on any medications. His family falls under upper-lower socioeconomic status under modified Kupus-Squammy scale. Coming to summary, a 34-year-old male with complaints of cough with expectoration since 20 days and dyspnea since 20 years comes under NYHA class 3 with bilateral lower limb swelling, lower limb edema since 7 days, not associated with fever, chest pain, and palpitations, probably right heart failure secondary to lower respiratory tract infection. Sir, can I continue?
Just continue.
Yeah, go ahead.
Coming to the physical examination, the patient is pale, diaphoretic, apprehensive, but oriented to time, place, and person. He is lightly built, thin and slender. Pallor is absent, icterus absent, cyanosis, pallor, icterus, cyanosis, clubbing, lymphadenopathy are absent, but peripheral edema present, bilateral and gore lower limbs, which is pitting type. Coming to the pulse, artery pulse is examined on the right hand over the right radial artery using 3-finger technique. The rate is 110 per minute. Rhythm is regular. Volume is low volume, which is grade 1. Character of the pulse is hypokinetic pulse. Condition of the vessel wall, no thickening of the vessel wall felt. Radiofemoral delay not detected. Other peripheral pulses present and symmetrical. Blood pressure is 90 by 60 mm of Hg and supine position measured on right hand. Respiratory rate 24 breaths per minute. Temperature 99 degrees Fahrenheit. Head to toe examination, no signs of infective endocarditis like ocular node, Janeway lesions are observed. No signs of Marfanoid hiatus observed. Coming to inspection, jugular venous pressure measured in right internal jugular vein, measured at 45 degrees inclination, and when lifting the chin and slightly rotating the head to the left side. Its height is 8 centimeters from the sternal angle, so jugular venous pressure is 13 centimeters of water, that is 9.6 mm of Hg. X and Y depths are reduced. Trachea is central on inspection, confirmed by palpation. On inspection, no scars, sinuses, dilated veins are present on the chest. Chest wall is symmetrical and no precordial bulge seen. No deformities like pectus excavatum, pectus excarnatum noted. Left parasternal heave is visible. And apical impulse was visible 1 centimeter medial to the mid-clavicular line in the 5th intercostal space. Coming to palpation, left parasternal heave felt by base of the hand and not obliterable, so grade 3, and synchronous with the apex, and sustained, which is indicative of RV enlargement with pressure overload. Apical impulse is felt 1 centimeter medial to the mid-clavicular line and felt in both 5th and 6th intercostal space, which is diffuse apex, and retraction seen medial to the apex, and the character of the apical impulse is forceful and sustained, that is heaving type. No thrills are palpated. Interpretation of the they are infraclavicular and epigastric pulsations are also visible. No palpable S3 and S4 are present. Coming to auscultation at the mitral area, both S1 and S2 are heard. The normal splitting of S2 into A2 and P2 detected along the left sternal border. There is wide splitting. I wrote by mistake. There is wide splitting of S2 in the S2, and loud S2 is heard in the 2nd intercostal space, and here A2 is louder than the P2. That's the 2nd intercostal space, the pulmonary area. There is also splitting of S2 to the right of the sternum, which is characteristic of corrected transversion of the great arteries, as pulmonary valve is present on the right. Coming to the murmurs, pansystolic murmur present at the maximal intensity at the lower sternal border, which is high pitch, blowing quality, indicating left atrioventricular valve incompetence. Ejection systolic murmur along with the along the left upper sternal border, which is soft in character. Respiratory examination, no accessory muscles were used, observed on inspection. Auscultation, normal vesicular breath sounds with bilateral rhonchi, bilateral infrascapular crepitations, inspiratory crepitations are noted. Personal abdominal examination and CNS, no significant findings on the in the remaining exam. Coming to the diagnosis, my diagnosis is lower respiratory tract infection with there is congenitally corrected transposition of the great arteries, which is supported by the. Yes, sir.
Deepti?
Continue, Gowtham. Continue. I think you were telling something, no? I think you were about to finish, or?
Yes, ma'am. I am done. I am done with my presentation.
Oh, sorry. Am I audible now?
Yeah.
Yes, ma'am.
Go to the last slide of your history. I just wanted to know, how are you supporting your diagnosis of LRTI?
Ma'am, cough with a sputum.
But was there any fever or anything?
Ma'am, there is no fever. Yes, there is no fever, ma'am. There is no fever.
How do you explain like infection with the absence of fever? Are you having any other cause in your mind? What are the common scenarios where you can get an infection without the presence of fever?
Ma'am, in immunocompromised state, we can get and chronic kidney disease, we can get infection without fever. Diabetes, we can get infection without fever.
Okay, okay. Any other supporting diagnosis for your cough with sputum? What are the common differentials you can have?
Ma'am?
Common differentials for the presence of cough with sputum apart from LRTA, anything else?
Ma'am, it can be if it is a large amount of sputum, then bronchiectasis can be considered, and COPD with COPD usually has a scant sputum, but chronic bronchitis can have a significant amount of sputum, and TB can consider TB if it is chronic.
Okay. Okay. Do you also get sputum in any non-infective causes?
Ma'am, GERD can
something more catastrophic or like not exactly sputum, but you can say
pulmonary embolism. Pulmonary embolism can get a frothy, pinkish frothy
pulmonary
sputum.
embolism or something else. What you told is correct, but it's not pulmonary embolism, it's pulmonary edema.
Yes, yes, ma'am. Sorry, pulmonary edema. Yes, ma'am. Yes, ma'am.
Was there any clubbing in this patient?
Ma'am, there is no signs of clubbing, ma'am.
Can you name some common respiratory causes for clubbing?
Ma'am, bronchiectasis, lung cancer.
Yes. Anything beyond that? All suppurative lung diseases can have empyema, bronchiectasis.
Yes, ma'am.
Okay. Okay. Any other? Okay, that's fine. I think others can take over.
Sure, sir. Gowtham, very well presented. Let's say you do an echocardiogram for your patient. What are you looking for?
Sir, I am looking for the cardiac output and usually in the congenital conditions, there can be septal defects and any valvular lesions valvular incompetencies can.
Which valve? No, I
Sir,
mean, see, now that
ventricular valve in this case, AV valve in this case, mitral valve.
you're thinking it's congenitally corrected TGA, no?
Yes, sir. Yes, sir.
So, which valve is more likely? So, congenitally corrected TGA, where will the mitral valve be? Mitral valve
it's not
right side or left side?
It's in the left side of what I'm looking for, the left side pathology, sir, in this.
So,
mitral
which means which valve is more likely to be incompetent?
Right side.
Sorry?
Sir, mitral valve will be on the right side in this case, sir, congenital corrected TGE.
Correct. So, it's in a low pressure circuit, no? So, it's in the pulmonary side. So, which side is more likely to have?
Sir, the left side, in the high pressure circuits.
Which means which valve?
Sir, the AV, which connects the right, left atrium and the right ventricle, sir.
Correct. So that is the tricuspid valve, no? In corrected congenitally corrected TGA.
Yes,
it will be tricuspid incompetence.
Yes, sir.
Okay. Otherwise, for your lower respiratory tract infection diagnosis, how would you want to manage the patient?
Sir, broad spectrum antibody augmentin.
So management would include investigations and treatment. So investigation,
so chest X-ray and along with the bronchial lavage can be. If the sputum culture can be done, sir. Sputum culture can be done in this condition.
Okay, so
And antibiotic sensitivity can be done, and so accordingly can be done.
okay, and then treatment.
Sir, if there is significant respiratory distress, then oxygen mechanical ventilation can be done along with antibiotics like augmentin.
Augmentin. What is the problem with going with only augmentin for a patient with a lower respiratory tract infection who has a congenital heart disease like this? So, what is the drawback of using a beta lactam only, monotherapy with beta lactam?
Sir, development of resistance to beta lactamase organisms. Beta lactamase producing organisms.
Yeah, or inherently resistant organisms. So how do beta lactams act?
Sir, by the peptidoglycan disruption of the peptidoglycan cell wall.
So basically, cell wall synthesis
Yes, sir.
is being inhibited. So some organisms which produce low respiratory tract infection don't even have a cell wall, no? For example,
Yes, sir, I have to read about it.
mycoplasma. So which antibiotic would give you an atypical organism cover also? So augmentin is correct. Augmentin plus.
Sir,
Augmentin is a brand name. You as a medical student, first of all, as a medical student, avoid using brand names. Say amoxicillin clavulinate. No, it's not a cephalosporin. It's amoxicillin clavulinate. So don't make it a habit of saying brand names. That will not make a good impression.
No,
But
he meant
amoxicillin,
sir mycoplasma, sir. Coverage for mycoplasma. He was having a third generation cephalosporin cement.
oh no, that's fine. But like in your exams, if you say augmentin or if you say Lasix, the brand names, if you say, the examiner may not like it, which is correct.
Correct.
So
You just
you're
should never
supposed to
not
say the
even use.
generic name. Yeah, the
Yes,
generic
yes.
names of the medications is what's supposed to be used also. Even we as prescribers should be prescribing like that. So that's the mandate from NMC.
Correct.
But cephalosporin would not be, again, the same class. No, they're also beta lactams. They can't act on unless the bacteria has cell wall. So you would use macrolides, azithromycin, something like azithromycin or clarithromycin. So when you're treating a lower respiratory tract infection, make sure atypical organisms are also covered.
Yes.
Okay. Rajashekhar, sir.
So, yeah, Akshay, sir.
Yeah.
Okay, then. Thank you, Gautam. Thank you so much. So we shall end it here. All the eight of them have done really well, up to our expectations for the finalists. Any concluding remarks from Dr. Akshay?
Yeah, really enjoyed the session because even I got to learn a lot thanks to the different participants as well as our other judges also. So I hope everybody and you all the participants should take it in a positive sense. If we have pointed out mistakes or if you have said something was wrong, it's all a part of the learning curve. Better to that's the way you learn. You make mistakes and you learn from your mistakes. So take it in the positive sense. Hope it was productive for you also. And the fact that we have participants from Philippines just speaks volumes about White Army and its reach, and also about the enthusiasm of among medical students. So hats off to Kishan and Aditya and the whole team at White Army. So thank you for having us here.
We had participants from many other SAARC countries as well, sir. But due to time, the time lag, time constraints, we could not include them. So excellent.
Hopefully
All
we can
is
do more.
possible, sir. Medicine, we have got a new dimension because of your Triple M classes. The students are liking very much, and so many are subscribing to it, and they are enjoying your classes. They really your explanations, the way you explain and make the things simpler is really extraordinary. All students are giving us very good feedback about your classes. We are really thankful and grateful to you for that. And you have been supporting us throughout, and You are always there with us to support and guide us. Thank you so much for being with us, sir. And yes, we could have. This has been a very long session. We could have, like students were also very good. The examiner get interest when the students are answering well. They're doing well. You tend to keep asking them more questions, and wonderful discussions we had. I hope all the students have learned a lot and got more confidence now. I am again stressing on that this is never a competition, but just like a mock examination. How to present to an examiner, how to convince them, how to impress them. All those things you learn here. Thank you so much. Soon we'll decide the best ones among all 8 were good. Among them, 3 best ones we will decide and share it in the group soon. Till then, thank you all the participants and the judges. Thank you so much.